Substance Use. Please silence all electronic devices at this time. If you have any questions, please raise your hand, and one of us, as Sergeant at Arms, will kindly assist you. Chair, we're ready to begin.
Good morning, everyone. My name is Councilmember Tiffany Caban, Chair of the New York City Council's Committee on Mental Health and Substance Use. Before we begin, I'd like to recognize that we are joined by the following council members: Councilmember Schulman, Lee, Aldebal, Ariola on Zoom, Felder, and we are also joined by the public advocate. Today's oversight topic is From Crisis to Care: How New York City Connects New Yorkers to Mental Health Services, and we will also be hearing two bills, Introduction 722, sponsored by Councilmember Schulman, which would require the quarterly reporting and publication of mental health emergency response data relating to Be Heard, and Preconsidered Introduction. Do we have a number on that?
No, it's just
Okay.
Considered,
Sponsored by Councilmember Lee and myself, which would establish a task force to study the current 988 system and create a public education campaign on mental health awareness. I want to begin today's hearing by speaking briefly about the case of Jabez Chakraborty, a New Yorker from Jamaica, Queens. His story reflects the broader systemic challenges in how we respond to and support individuals living with a serious mental illness. Jabez is 23 years old and lives with schizophrenia and receives treatment and medication. After a mental health crisis in December, his family called 988 and requested a mobile crisis team, and the team didn't arrive at his home until 2 days later. He wasn't taken to the hospital, and his family was then advised to request involuntary transport, after which Jabez was discharged after just 3 days. His family attempted to enroll him in an intensive daily treatment program, but he was placed on a wait list. And I just want to point out that a lot of what we end up seeing and talking about in a person's life like this, that culminated in a police officer shooting him while he was in a mental health crisis, people will watch the video and say, well, I don't know, this is complicated. It's justified because this young man was holding a knife. But it does not take into context every single moment that him and his family was failed, that he could have had access to a sustained continuum of care that could have prevented the crisis. And it does not change the fact that these officers were fundamentally the wrong responder, period. And it could have had a fatal outcome. And I mean, we're lucky that he is still alive today, but also that trauma is one that's going to last a lifetime for him and his family. And it is an utter failure by our city that is how this culminated. I think this moment points to one of the most persistent gaps in our mental health system, and it's the space between stabilization and sustained care. A hospital stay or crisis intervention, however necessary, is not a destination, it's a bridge. And without timely connection to programs like intensive mobile treatment, assertive community treatment, long-term community-based supports, individuals like Jabez are left to navigate an often fragmented system on their own, and families are left holding the weight of that failure. And on the morning of January 26, Jabez experienced another crisis. His family once again sought emergency assistance, and what followed was a tragic encounter with law enforcement, and it could have been prevented. And so this case illustrates the profound consequences of gaps in coordination and of a system that too often treats crisis response as the end of care rather than the beginning of it. And when institutions are under-resourced, when families cannot access timely support, and when wait lists and red tape block access to ongoing treatment, the burden falls hardest on those who are the most vulnerable. And at its core, connecting New Yorkers to mental health care is not just a public safety issue, it's a matter of dignity. People living with mental illness are not problems to be managed or crises to be contained. They are our neighbors, our family members, our colleagues. They deserve the same opportunity as anyone else to live full, meaningful lives and to be active value members of their communities. And when we fail to provide timely, sustained, and compassionate care, we are not just failing a system metric, we are telling a person that they do not belong, that their struggles make them other. And that is a message that no New Yorker should ever receive. And we owe it to Jabez and to every New Yorker like him to do better, not only in how we respond to crises, but in how we ensure that every person who needs sustained mental health support can actually access it. Effective care means more than stabilization. It means supporting people and building lives that they find meaningful, maintaining housing, reconnecting with family, and participating fully in their communities. And programs like intensive mobile treatment and assertive community treatment exist precisely to provide that kind of holistic, person-centered support, and we must ensure that they are funded, that they're staffed, and accessible to all who need them. And I share this story to center the voices and experiences of the New Yorkers we serve. Through this oversight hearing, we aim to strengthen the very systems that connect people to care, from the first call to 988 to the long-term treatment and community connection that make a full life possible. That's what this hearing is about. So in closing, I would like to thank the administration for being here, as well as the committee staff who worked to prepare for this hearing and my own staff. And I'm going to now pass the microphone to Councilmember Schulman for a brief statement.
Thank you very much, Chair. And before I get into my statement, I want to echo what the council member said. And also, you know, the bridge we talk about, I used to work in the health and hospital system some years back, and even that bridge doesn't work because folks come in and then because there's no money to keep them, they don't keep them, and then they put them out on the street. So that's not a response. That's not an answer. And the case she's talking about, there's thousands of them like that. So I want to talk about, good morning, everyone. To Chair Caban, thank you for having me here today, and members of the Committee on Mental Health and Substance Use. I'm Councilmember Schulman, Chair of the Committee on Health. I appreciate the opportunity to speak today about this important legislation that I have. As many of you know, we are in the midst of a mental health crisis, both locally and nationally. It's estimated that about 23% of all U.S. adults live with a mental illness. This is in line with the 25% of adult New Yorkers experiencing a mental health disorder in a given year. Intro 722 is about transparency and data, which we don't have, interestingly enough. It would require the Office of Community Mental Health to report quarterly on every 911 call identified as involving a mental health emergency, including how those calls were heard and whether a behavioral health emergency assistance response division BHEARD team responded, and submit that report to the mayor and city council speaker. Additionally, this legislation would require the NYPD and FDNY to include the unique identifiers generated by their respective computer-aided dispatch systems and to indicate whether BHEARD was dispatched and able to respond. Why does this matter? Because we cannot improve what we do not measure. If we are serious about building a public health-centered crisis response system, we need clear, accessible information about where BHEARD is working, where it is not, and why. This data will also help emergency responders better prepare for emergency calls. I want to thank the Committee on Mental Health and Substance Use staff for their work on this legislation, and I urge my colleagues to support Intro 722. Thank you, Chair.
Thank you. And now we'll hear from Public Advocate Jumani Williams.
Thank you. As mentioned, my name is Jumani Williams, Public Advocate for the City of New York. I'd like to thank Chair Caban and the members of the Committee on Mental Health and Substance Use for holding this very important hearing. Almost 1 in 4 adult New Yorkers experience a mental health disorder in a given year. Mental illness affects people across all communities and demographics, wealthy and poor, young and old, black and white. But not everyone is able to access treatment, and not everyone who accesses treatment gets the kind of care they need. There are many reasons why New Yorkers who need mental health care either do not or are unable to access it, including cost, stigma, language barriers, and logistics. A report published last year by DOHMH found that in 2023, about 14% of New Yorkers, almost 1 million people, reported that there was a time in the past where they did not get the mental health treatment they needed. As is the case across healthcare more broadly, Black, brown, and indigenous people fare worse when it comes to receiving effective mental health treatment. There are a few instances when the police should respond to a person in mental health crisis. More often, the presence of officers, particularly in uniform, only escalate an already tense and precarious situation. Most recently, we have seen this play out in the shooting of Jabez Chakporty, a young man diagnosed with schizophrenia experiencing a mental health crisis. According to his family, who called emergency services, it requested EMS, not police. Mr. Chakporty was not a threat until police arrived and their presence escalated the situation. I am thankful that Mr. Chakporty is alive and recovering from being shot 4 times, and I'm still questioning the decision to criminally charge him. Best I've heard was to help him get care, but I'm not sure if that was the best way. I want to associate myself with the words of the chair about very often we see the last second that gets played out without everything that happened before it. What is especially tragic about the case of Mr. Chakporty is the fact that his family repeatedly tried to connect him to crisis care in the month leading up to the shooting. In December of last year, a mobile crisis team visited him and left without transporting him to hospital. Later that month, police transported Mr. Tripodi to a hospital, but he was discharged after 3 days due to understaffing. Cycling through hospitals without effective connection to care is unfortunately common. Marshall Simon, the man who published who pushed Melissa Elisa Go in front of a train in 2022, had been hospital at least 20 times, according to his lawyer. They're either cycling in and out of hospital or in and out of Rikers Island. Mental health care must go hand in hand with housing. A stable connection to care is nearly impossible when a person does not have a place to live, and the stress of homelessness impedes effective treatment. As a part of FY 2026 New York State budget, Governor Kathy Hochul insisted on expanding the criteria to involuntarily commit someone for psychiatric treatment. Now the interpretation that a person is unable to care for their basic needs, not just that they present a danger to themselves or others, is enough to involuntarily take a person for mental health evaluation, a tool which, while is important, should be a last resort. With this law now in place, we need forceful oversight to prevent abuses, to determine whether people in the field can accurately, fairly, equitably assess individuals under the new criteria, and provide help rather than perpetuate harm. It is also critical to ensure that when someone is hospitalized, they are placed on a continuum of care to ensure that people are not cycling through hospitals, jails, or homelessness. Though it can be a life-saving tool, it is important to also name the limitations and potential harms of immediate insistence on involuntary treatment. Hospitalization is destabilizing and can cause a person to lose their job or housing. The goal of hospitalization is not long-term care, but short-term stabilization. And a person who is struggling with homelessness or serious mental illness prior to hospitalization is less equipped to comply with a longer-term treatment plan, especially without additional community-based support. Research shows that involuntary commitment can negatively affect a person's earnings, which leads to poor outcomes. It can also show distrust with healthcare, which is problematic when a person needs voluntary continual care outside of the hospital. Every person with a mental health condition is different. There's no perfect solutions. It is clear, however, that the city has not yet met its mandate to properly care for some of the most vulnerable communities. I look forward to working with this administration to ensure that those in need of care are met with compassion and dignity. I expect they have the same kind of expectations I did, unlike the last administration where we struggled. Thank you very much.
Thank you. And now we hear from Councilmember Lee to give some remarks.
Thank you, Chair Caban, and it's very exciting to see you in this new role and very excited for your heart, passion, and dedication to continuum of care and crisis management work. So very excited to see what you do with this committee. And it's great.
Each other's biggest cheerleaders,
Yeah.
if you hadn't noticed.
Yeah.
I'm a fan.
Yeah. And it's great to see a lot of the advocates here. Good morning, everyone. And of course, Dr. Wright and the administration, Lakeisha, nice to see all of you here. And thank you for the opportunity to speak on this legislation that I'm proud to co-sponsor with Chair Caban. A mental health crisis is frightening, and in that moment, people need a human voice, clear guidance, and real help. 988 is meant to be that lifeline, but New York City must ensure it consistently delivers a calm, informed, and connected response. The bill focuses on two key improvements. Number one, a 988 improvement task force. This task force will review call handling and recommend concrete improvements, including better training, de-escalation scripts, and timely dispatch of mental health professionals. The goal is to ensure people are connected to quality support after the call, and importantly, the task force will include people with lived experience. And secondly, a public education campaign. Right now, too many New Yorkers don't know what 988 is. This campaign will provide practical, everyday information on recognizing warning signs, assessing risk, when to call 988, and how to describe the situation. It will also clearly explain available services like mobile crisis teams and provide printed materials in community locations. People should be able to reach out and know that someone will pick up, someone will understand, and someone will help connect them to care. And just to add, this is, I think, just a piece of the puzzle that we're trying to fix. And I think with Councilmember Schulman's bill and a lot of the other bills that we've tried passing in the council, it really is trying to emphasize how not to let people fall through the cracks. And I have to say, just as an anecdotal narrative perspective, whenever I go to forums or, you know, any sort of group or community meetings, I kind of do a poll test of, you know, raise your hands if you guys know what 988 is. And a lot of folks still don't know what 988 is. And I remember speaking to the folks at the state about a year and a half ago, 2 years ago, and there was supposed to be a lot of funding that was put into this, but hopefully those resources, I don't know if they've funneled down to the city, but hopefully that's something we can do more of around the 988 campaign to prevent deaths like when Rosario, as well as folks like Jabez that have been shot at. And these are situations that should not happen. And so we want to make sure that our mental health system, we know it's broken, it's been deinstitutionalized, it's been underfunded for decades. And so we want to make sure we do everything possible to help the awareness side. So thank you.
Thank you very much. Just quickly before I pass it over to the committee council, just a heads up for you all. You're going to see, I have to take breaks. I've got to stand up sometimes. I have a chronic pain issue. So like if I'm standing up, I'm not trying to lord over you, but it might be possible that I might need a bio break or something like that. So thank you. I am going to turn the mic to the committee council to administer the oath.
Sorry. Now, in accordance with the rules of the council, I will administer the affirmation to the witnesses from the mayoral administration. Please raise your right hand. Do you affirm to tell the truth, the whole truth, and nothing but the truth in your testimony before this committee and to respond honestly to council member questions? Thank you. Prior to delivering your testimony, please state your name and title for the record, and you may begin when ready.
Good morning, everyone. Before I read my testimony into the record, just want to say I appreciate your sentiments and the comments you made, Chair, about the concern with the shooting, and certainly we are very much concerned as well. And although I cannot speak to individual cases specifically, I can let you know and be assured that we are looking into it internally and that we will look for all possibilities to improve and to do better. And so I appreciate the sentiments, and I appreciate the sentiments of the chairs that are here and the different committee members that have spoken. It's always good to see you, Chair Lee, and congratulations on being on the Finance Committee, to chair the Finance Committee, and congratulations, Chair Caban, and it's always good to see you, Chair Shulman. It's always a pleasure. And so now I'll begin my testimony. My name is Dr. Gene Wright, and I am the Executive Deputy Commissioner for the Division of Mental Hygiene at the New York City Department of Health and Mental Hygiene, the Health Department. I am joined today by Jamie Nichols, Assistant Commissioner for the Bureau of Mental Health, Dr. Rebecca Lynn Walton, Assistant Commissioner for the Bureau of Alcohol and Drug Use, and Lakeisha Grant from the Mayor's Office of Community Mental Health. Thank you for the opportunity to testify today. We recognize that mental health is central to overall health. We put this into action by employing a public health approach to supporting the mental and behavioral health needs of all New Yorkers. We serve as the city's mental health strategist and work with more than 200 community providers to deliver over 800 programs. We also recognize that we are working within a complex and imperfect system in this city and this country. This work exists within a context shaped by historic injustices. We are committed to working every single day with providers, communities, experts, and families to improve the mental health system and support all New Yorkers. Today, I'll discuss two important pillars of the continuum of programs we support: crisis services, which are short-term interventions for all New Yorkers, and mobile treatment, which are long-term interventions for the highest need New Yorkers. First, crisis services. What constitutes a mental health crisis can look very different from person to person. You do not need to have a diagnosable mental illness or serious mental illness. A crisis may be triggered by a myriad of different internal, emotional, or cognitive experiences. Internal or interpersonal conflicts, including abuse or violence, or environmental stressors, such as neighborhood safety. It is essential to recognize the complexity and nuances of these experiences in this discussion. Providing support in moments of mental health crisis is a tremendous duty that we share with our city and state partners. My colleague from the Mayor's Office of Community Mental Health are here today to answer questions regarding the Be Heard program, which is an important part of the mental health care continuum. I will speak to the crisis response infrastructure that the health department directly administers. Crisis services we support can be categorized into three groups: someone to call, someone to respond, and somewhere to go. NYC 988 is that someone to call for every single New Yorker. When someone experiences a mental health crisis, it can be helpful to talk to someone we trust: a friend, a family member, a religious advisor, a peer, a mental health professional, or a healthcare provider. Anyone can reach out to NYC 988 at any time of the day, any time of the year, and any time of the night. Anyone can also speak to a trained counselor, crisis counselor, or peer support specialist. New Yorkers can reach out via call, text, or chat. NYC 988 counselors and peers will listen to a person's situation and help them through a moment of crisis with emotional support and coping skills. NYC 988 provides counseling and local resources consistent with national standards and best practices. Counselors help connect people to ongoing mental health services that meet their needs. In New York City, these counselors refer people who do not need immediate care to community-based mental health providers and community resources. There is also an online database of service providers available to the public on NYC 988 website. Sometimes a person may be unable or unwilling to seek mental health services to get through their crisis. This brings me to someone to respond. In these situations, NYC 988 will dispatch a mobile crisis team to visit the person wherever they live within a few hours, 8 a.m. to 8 p.m., 7 days a week, citywide. Mobile crisis teams are our cornerstone short-term intervention for non-life-threatening mental health crises. Mobile crisis teams represent a significant portion of the mental health crisis response infrastructure in the city. In fiscal year 25, over 18,000 referrals were made to mobile crisis teams. The city is currently served by 25 mobile crisis teams, 22 of which are contracted by the health department. Mobile crisis teams include both master's level mental health clinicians and peer specialists. They meet face-to-face with the identified individual in crisis, as well as their family or other support systems, to engage, assess, de-escalate, and connect individuals to the most appropriate services. Meetings typically occur wherever the person resides, such as a private apartment, a supportive housing setting, or emergency shelter. After a crisis is de-escalated, people can be connected to outpatient or inpatient care if appropriate. We consider mobile crisis teams a short-term intervention, typically ranging from 1 to 3 contacts in a 2-week period. Some people need more support than they can access in their homes. These folks might need somewhere to go, our third and final category of mental health crisis services. For these situations, crisis residences provide an alternative to hospitalization for people experiencing mental health crisis. They are warm, safe, and supportive home-like places that offer 24-hour peer support, group activities, and connection to clinical services as needed. Guests typically can stay for up to 1 week. These open-door settings enable people to remain connected to their lives, school, work, family, and while getting additional supports through a crisis, people may be referred to a crisis residence by New York City 988, a mobile crisis team, their mental health provider, or through a self-referral. For continued support and treatment, all these programs can connect New Yorkers to outpatient clinics and community-based services. For the subset of people served by mental health programs who are homeless, service providers assist with referrals to supportive housing, of which the health department contracts over 13,000 units. For those in need of long-term care that extends beyond clinic walls, we have mobile treatment programs that allow providers to literally meet people where they are. Mobile treatment long-term interventions for the highest need New Yorkers is what I'll cover next. Mobile treatment programs are specially care designed for individuals who have the most complex behavioral health needs. We use the term serious mental illness to refer to this combination of behavioral health and emotional needs and functional needs. These are long-term interventions for a small subset of high-need New Yorkers, unlike the crisis services I previously described. The Health Department manages the referral system for these specialty services, New York City's Single Point of Access, or SPOA, and contracts with community-based organizations and hospitals to administer services, namely Assertive Community Treatment Team, or ACT, the Intensive Mobile Treatment Teams, or IMT. Providers make referrals to SPOA through our website. Referral sources include crisis service providers, I just described, as well as community and based mental health shelters and housing providers who recognize that their client could benefit from a high level of care. Hospitals, jails, and prisons also make referrals to SPOA as a part of their discharge planning process. Clinicians at the Health Department SPOA review eligibility, assign people to the appropriate level of care and location of care. The SPOA system received 4,952 referrals in fiscal year 25. Our clinicians will determine if someone is eligible for ACT and IMT, which have a combined capacity to serve about 6,500 people at a time. ACT is an international evidence-based model that provides mobile, community-based mental health and substance use treatment to people with serious mental illness whose needs have not been met by clinic-based care. Teams are multidisciplinary, comprised of peers, social workers, psychiatrists, nurses, who will visit clients wherever they live to administer medication and support clients in achieving goals such as housing and job placement. ACT teams are licensed by the State Office of Mental Health, or OMH, and contracted by both OMH and the Health Department. In New York City, there are 80 teams serving approximately 5,500 New Yorkers. ACT teams are operated by a total of 20 community-based organizations and 15 hospitals, including NYC Health and Hospitals, state-operated psychiatric centers, and private hospitals. Some of these teams specialize in certain populations. 6 forensic ACT teams work exclusively with eligible individuals with current or past criminal legal involvement. 10 shelter-partnered ACT teams work exclusively with eligible individuals residing in mental health shelters. IMT provides mobile treatment like ACT, but was created by the Health Department in 2016. IMT serves people with more complex cross-system involvement, housing instability, and transience, who sometimes have more complex or less clear behavioral health diagnoses. Multidisciplinary IMT teams include behavioral health clinicians and peer specialists who bring services to wherever participants are in the community. The street corner, a shelter, or a residential setting are just some examples. IMT provides mental health and substance use treatment, including medication, care coordination, and behavioral health support. The team's individualized service frequency and duration, and participants may stay in the program as long as they require supports. IMT teams may also continue to provide services to participants during hospitalization, incarceration, and residential substance use-related rehabilitation to promote continuity of care. Our mobile treatment programs, accessible through SPOA, ACT, and IMT, are distinct from crisis services. Both are essential interventions that address different needs and play pivotal roles in the continuum of mental health care. I will now turn to the legislation before answering any questions. Pre-introduction T 2023-3879 refers to the establishment of a task force on 988, a public education campaign. We support the intent of the bill and look forward to further conversations about how existing efforts meet these needs. The Health Department is planning multiple 988 and mental health awareness campaigns this year. Additionally, there are mechanisms in place, to improve the NYC 988 program, which includes stakeholder and community input. The Health Department is deeply committed to this work and has been for decades. I want to thank the providers who carry out this important and challenging work every single day. I am pleased with the progress we have made, but we still have so much more work to do. Thank you for the opportunity to testify today. I look forward to answering your questions.
Good morning. My name is LaQuisha Grant, Deputy Executive Director for Mental Health Access at the Mayor's Office of Community Mental Health. And before I begin my formal testimony, I too want to echo Dr. Wright's congratulations to Councilmember Lee and to you, Chair Caban. I know how passionate you are and how well-versed you are in non-police response and alternative response, and we truly look forward to working with you. So I'll begin my testimony. Good morning, Chair Caban and members of the Committee on Mental Health and Substance Use and Public Advocate Williams. I am LaQuisha Grant, Deputy Executive Director of Mental Health Access for the Mayor's Office of Community Mental Health, OCMH. Thank you for the opportunity to testify on Intro 722 and answer any questions about our critical role in addressing mental health needs in our city. The Mayor's Office of Community Mental Health, OCMH, works to develop scalable approaches to mental health care by bridging policy, clinical practice, and community expertise, all with the goal of improving mental health outcomes for all New Yorkers and strengthening access to the supports they need to live healthy and fulfilling lives. Codified into the city charter in 2021, OCMH is also tasked with identifying gaps in care and driving evidence-based interventions and policies to meet the needs of all New Yorkers. OCMH appreciates the intent of Intro 722 to enhance transparency and public understanding of how mental health emergency calls are resolved across city agencies. We share the committee's commitment to accountability and to transparency as it relates to how the city is responding to mental health emergencies. At the same time, we must respectfully note significant operational and legal considerations associated with the bill's current reporting requirements as written. OCMH, along with the Fire Department for the City of New York, in their position as a healthcare provider for the Behavioral Health Emergency Assistance and Response Division, BHEARD program, have substantive concerns regarding patient privacy and data integrity. The bill references treatment-related information and data elements such as medical treatment on scene, voluntary versus involuntary transport, crisis counseling provided, and referrals to community-based providers. In the health data context, these elements reflect an individual's interaction with emergency medical services and the mental health system. When they are linked to a unique identifier rather than presented in aggregate, it may constitute protected health information under the Health Insurance Portability and Accountability Act, or HIPAA. Requiring the publication of unique identifiers alongside treatment-related data on OCMH's website and the Open Data Portal presents a meaningful risk of re-identification and associated HIPAA liability. Even without unique identifiers, the required data points, including precise location, could easily be connected and traced to individuals, especially in residential buildings, exposing the identities of New Yorkers during their most private and sensitive moments. An individual's risk, real or perceived, of being identified in a data set such as this weakens trust and may dissuade individuals from calling 911 in times of need, thus endangering public health and safety. We respectfully recommend careful legal review of these provisions and welcome continued collaboration with the committee and our partner agencies to advance transparency goals while safeguarding patient privacy and preserving the integrity of sensitive health data. Further, the legislation would require reconciliation of roughly 160,000 mental health related calls each year across multiple distinct and non-integrated systems operated by the New York City Police Department, the Fire Department of the City of New York City Health and Hospitals, and private hospitals that provide voluntary ambulances in the 911 system. Compliance with Intro 722 would necessitate the hiring of data staff to design and maintain interagency data pipelines, conduct cross-system reconciliation, validation and analysis, and oversee data governance to ensure adherence to applicable legal standards. In addition, the bill would likely require investment in secure, HIPAA-compliant technology infrastructure, a data integration platform, as well as a data reporting and dashboarding tool. Finally, there is no single 911 call type that encompasses every mental health emergency, and calls sometimes get reclassified in the course of the response. The terminology should be refined to better align with operational realities. In closing, we thank the chair and members of the committee for your continued leadership and partnership on issues affecting the mental health and well-being of New Yorkers. OCMH remains firmly committing to advancing health-centered approaches to crisis response, one that provides New Yorkers with the most effective and compassionate care at their moments of need, promotes transparency, protects patient privacy, strengthens interagency coordination, and builds systems that are equitable and sustainable. We look forward to continued collaboration with the Council to ensure that our collective efforts enhance accountability while upholding our shared responsibility to safeguard the health, dignity, and safety of all New Yorkers.
Thank you. Thank you very much. I am going to start with some brief questioning because I want to be able to hand it over to my colleagues sooner rather than later, and make sure you sign up for questions with the committee council. I'm going to start with 988. I'm going to resist the urge to immediately go to be heard. But yeah, I'll start here. And thank you everybody for your testimony and for your participation. But when someone calls, texts, or chats with NYC 988, can you just talk about who answers, what are they trained to do, and walk us through what happens in the first few minutes of contact? It was touched on, a little bit in the testimony, but hoping that you can get a bit more granular there.
Good morning. I'm Jamie Knuckles, Assistant Commissioner for Mental Health at the Health Department. I can handle that question regarding 988, which is operated as a part of the national 988 network. So SAMHSA establishes the standards for 988 and works with local providers across the country to answer calls from their jurisdiction. Just last month, so the SAMHSA re-procured the national administrator contract for 988. That's routine re-procurement. There was, so that period closed on February 27th. In that sort of national procurement process, there's all the standards in great detail about what 988 is expected to do, and then our local expectations complement those sort of national standards. And so we have a contract for Vibrant to operate 988 locally, and they're answering or they're handling about 400,000 contacts a year. Every call is answered by a trained crisis counselor. So those are folks who go through about a month-long training to provide, there's a sort of a didactic piece and a practical piece where they're trained to answer calls with supervision and gradually independently. So
before you move on to the next part, can you go into that, like that month-long training? What does that entail?
Sure. So I'll do my best. It's a long training, so I don't know that
Yeah.
I'll get all of the content. But basically, it's learning. There's technology piece, right, for managing the call answering system and text and chats, and then there's the stages of a call where a person comes in. You're learning how to build in a limited amount of time, right? These are brief interactions. Build a bit of rapport with the person who's calling, understand what they're calling about, do some problem solving, and then sort of wrap it up and document. So those sort of rough stages of a call. They're doing risk assessment with respect to suicidality and homicidality, and then they have to understand active listening, problem solving, how to build coping skills, give folks some tools to manage stress or whatever distress they're experiencing, and then referral if that's something that the person's interested in, helping them connect to local resources that meet their needs, and documenting that in the case record system.
Yeah.
So it's building those skills.
I have a question about referral because you mentioned that this is a nationwide network. Somebody who picks up the 988 call that calls from New York City might actually get on the phone with somebody who is located out of state. And my understanding is that if you luck of the draw happen to have somebody out of state pick up the phone, that person may not then, by virtue of being out of the state, make a referral to certain programs because of that. Can you talk a little bit about that?
Sure. So I don't think that's how it's operating here. So the calls from New York City, based on cell phone routing. Most people are calling from a cell phone or texting or chatting. There are landlines too. So they're routed to the counselors that are New York City based. And there are overflow plans in place. If, for example, there's a surge in calls, if 100 calls come in a 20-minute period, right, for some unknown reason, there's an overflow, and the overflow in our city goes to a Long Island-based call center, and that's a sort of a fail-safe. Also, if there's like during Hurricane Sandy back then, there were like call center problems, right? So there's some fail-safes, but the next tier is just outside of the city. Most of the people who call, though, are actually looking for in-the-moment support. The number of folks who are interested in referrals is low. Most people want somebody to listen and support them through a period of distress. And then if there's referrals, we offer folks up to 3 referrals that meet their needs, things like language, insurance, level of care.
Yeah, no, I think that makes sense. I know it's probably, I think the range is somewhere in the like 80 to 85% range where people are looking for that conversation and don't necessarily need the referral. But then that other percentage of folks who do need the referral, it's a pretty acute need. And I guess, when you talk about that overflow, I understand that the goal is to get a New York City-based person on the line with the caller. But there are times, to your point, that they are routed to an out-of-state operator. And so, I guess, what is the protocol to ensure that if they're part of that subset who they need a referral, what's the protocol that ensures they can still be connected to a local crisis team?
Sure. So it's mostly the failsafe is out of city, not necessarily out of state, right? So there's a Long Island backup, or we have counterparts on Long Island, and they'll answer it. And then I think there may be a third, option, which could also be out of state if for some reason. But these are low occurrences. Most often, people are reaching a New York City-based counselor. If let's say it goes to a Long Island team, they can then reconnect back to New York City if for some reason there's a mobile crisis referral that's needed, which is very specific to how our city operates.
Yeah. And I recognize the challenges and the capacity issues, and certainly I think lots of folks here support sort of like the beefing up of the capacity of the 988 system and beyond. And I know that you know this, but to state it for the record, like that low occurrence is still a human being seeking care. And we've heard some of the worst stories about what happens when that one person is unable to get that care. So it's certainly like endeavoring to make sure that we're not letting anybody fall through the cracks. So what does the handoff look like? Like, let's say you're part of that subset of people who need a referral. How does 988 connect them to the services, or does the person have to then like follow up themselves? What does the handoff look like?
So it depends on the type of service that the person's interested in. The most common scenario would be a person who's interested in mental health counseling therapy, right? They want to go to a mental health clinic, of which there are about 200 or more than 200 licensed mental health clinics in our city. The 988 protocol is to offer people 3 referrals, right? That's ideal, giving them like I said earlier, clinics that meet their parameters. And this is just one example clinic. They will offer, if the person's interested, for a warm transfer to that clinic if it's open at that time, right? They can't warm transfer to somebody to a clinic that's not open at the moment. But they will offer that. I think most people say, just, give me the information. I'll call when I'm ready. I think people have a limited amount of time on the phone, often want to think about it. Sometimes there's ambivalence about a person's, willingness or interest in following through. So they'll get the information over the phone.
Is there, if let's say it's not open and the person is going to do it when they're right or whatever it is there a protocol for just being like, hey, we're checking in. How are you? Did you reach out to this thing?
There is a protocol. People are offered follow-up contacts and may accept it, right? It's offered on a voluntary basis. Not that many people accept it. And of the people that do accept it, most don't pick up the phone when they call out, right? We know we get lots of calls in our phones right now, and most people don't answer them. That's just the reality.
The spam.
Yeah.
It's hard. We get too much spam, so we don't pick up calls.
But the good news is that it's open 24/7, 365. And so people call back. And we know people call back and use 988 more than once. That's not uncommon. But there is follow-up offered. And we can provide the information, like over the phone. If you want me to send you the clinic information over text, we can text it so that you don't have to jot down the name of the clinic and the phone number, or send it via email. So there's a couple options so people don't have to write it all down in the phone call.
Okay, thank you. I'm just going to go back to those call takers for a second. We talked about the training, but are they also? I'm assuming. I mean, is it correct that they are also trained specifically on just some of the mental health services that are kind of unique to New York City? So specifically our crisis respite centers, our mental health clubhouses, our youth mental health clubhouses, like those things.
Yes.
Great. Thank you. Okay. Could you go into a little bit more detail on for the different kinds of interactions that you have with a call taker, how a crisis contact is resolved? You talked about what happens when it's deemed appropriate to make a referral, but can you just talk about what follow up after a crisis contact where maybe a referral wasn't something that, when it was a situation where the person was helped through their crisis, maybe they were able to have their nervous system kind of recalibrate, whatever it might be, and then how is DOHMH tracking the longer term outcomes for individuals who call?
Yeah, so if a person, we wouldn't refer a person in crisis to a clinic, right? So I want to be clear. Those are for non-crisis situations, for sort of routine care. So routine. So if there is an urgency to the person's mental health situation, and they're unable or unwilling to get themselves to care. Some people may say, look, I have a therapist actually. Okay, I'm going to call them right now, right? That's a great plan. Calling somebody we're thrilled with that. If they're unable or unwilling to get to some sort of a treatment provider, 988 will dispatch a mobile crisis team. So we use the word dispatch. It's more than a referral, right? We're not giving them a phone number and saying, here you go, you can do what you like.
Yeah.
The 988 is collecting information, right? And giving that sort of assignment to the mobile crisis team that, first of all, covers the age, right? We have child-focused and adult-focused mobile crisis teams, and the neighborhood, right? And there's some overlap in neighborhoods for redundancy so that we have capacity. And they'll make that assignment to a mobile crisis team that will get out where average response time is just under 2 hours citywide right now, which is fantastic. they operate 7 days a week, 8 a.m. to 8 p.m. And so they are going out and providing in-person services. And those mobile crisis teams then are the ones who are reporting back to the health department on the outcomes of their intervention. So that is not coming from 988, who has a sort of a telephonic and finite, period or limited period of time with the person on the call. The outcome is coming from the mobile crisis provider themselves.
Thank you. I want to go just back to a second for the call takers and the training. Obviously, there are also instances, people are calling about mental health challenges. Dual diagnosis is obviously a thing. There may be folks who are navigating mental health challenges while also navigating substance use. How are 988 operators trained to integrate harm reduction principles into their responses, if at all? So the things that are beyond just hey, can we talk about a detox center or something like that, but just safe use, safe consumption, and some of the other things that we talk about in harm reduction. And does the current referral process include harm reduction services beyond outpatient detox?
Yes, so they are. So 988 is referring to the full array of substance use, harm reduction, and treatment services, not just detox. I think
You have some examples of
sure.
what
So
those are?
yeah. So for example, where naloxone and opioid overdose prevention providers, we've made sure to give the sort of updated directory of those that are developed by my colleague Dr. Lynn Walton to make sure they're incorporated into the 988 directory so that the counselors can make those referrals.
Great. And is it part of their, I guess, do you have a sense of how deep or what the breadth of the training specifically on harm reduction principles and treatments are for call takers?
Yeah, I mean, I think harm reduction approach is the standard of care. It is what we do everywhere, and so it's built into it for substance use as well as other situations.
Totally.
It's not just limited to substance use. So that's expected across all of our programs.
Great. And when 988 determines someone needs emergency services or involuntary transport, what's the protocol for determining law enforcement and involvement? And how is DOHMH working to minimize unnecessary police contact in those situations?
Yeah, so I think the entire approach for 988 is to provide a term. I don't love the term, but it's important, the least restrictive option, right? So that is their default training. That's part of the training that the new counselors receive. And so they're always looking for the least restrictive intervention. And often that's telephonic, like I said, just providing that in the moment support. They're assessing for risk in terms of a person's thoughts of hurting themselves or others, any plans to do so or means to do so. If they assess that risk, a person to have sort of thoughts about hurting themselves or somebody else, and a plan, right, more than a thought, because sadly, suicidal thoughts are not entirely uncommon among humans, right? Life is difficult, and so I think just having a suicidal thought is not a reason to transfer someone for emergency response. But if upon further probing, there is a concern about safety, imminent safety, they will engage emergency services. That's done infrequently, and typically the counselor will remain on the phone with the person, and their colleague or supervisor will engage 911 for emergency response. They are not making decisions about removal. Those are made by clinicians on site.
Right. And I think, I appreciate you talking about sort of the protocol being least restrictive. I think it's worth also mentioning that I assume it's correct that also the part of that protocol is it's not just because it's least restrictive, it's least violent, it's least traumatizing.
Yeah,
and because those things, when not absolutely necessary, are actually associated with worse outcomes, whether it's increase of risk of overdose later on, increase of risk of suicide attempt later on, or just simply the studies and data that shows that there are negligible differences between the outcomes of inpatient treatment and outpatient treatment, right? Sorry, I just want to make sure that's on the part of the hearing record, but does that sound about right?
So there's the outcomes of inpatient treatment. I don't think there's evidence comparing the outcomes of inpatient mental health treatment with outpatient treatment.
Well,
Generally,
substance
yeah.
use. There are for substance.
Oh, substance use. Yeah, I think that would be a Dr. Lynn
Yeah.
Walton question.
Okay.
That body
a
of literature.
fair characterization.
Yeah.
So I would say that when you include medication for addiction, the outcomes are tremendously good. A lot of our models, and I would say outside of New York City, much more of our treatment in New York City is outpatient than inpatient. So we really focus on outpatient and getting people medication the day that people are accessing, also through harm reduction programs, because we know a lot of people I've worked with many people who may have been kicked out of 10 programs over the course of their lifetime and understandably don't want to go back to that same setting. And so we make sure that there's a full continuum. So I would say that when good practices are in place, treatment is incredibly effective, and it can be incredibly effective inpatient, outpatient, and in the harm reduction programs as
Right.
well.
Yeah. Well, and that was my point. Sort of like if we're going to go with least restrictive, most autonomous, right? When it's good treatment, there are negligible difference in terms of outcomes for inpatient and outpatient.
I think it depends on what the need is, though. For example, if you're detoxing from barbiturates, you definitely need some higher level care.
Yes,
so
because
that's
you
why
can't
I
be
would
left. Yes,
yeah.
because
So I think
that is a health
yeah.
danger in terms of you can't be left
Yeah.
unattended because you need a medical professional to
Yep.
navigate you through that.
Yeah.
For sure. Thank you. You had written down a question. Sorry. What happens when a member of the public calls 988 on behalf of an individual who appears to be in mental health distress in the community versus calling 911? And like, what's your suggestion for folks? Should they do that?
Yeah, humans should care for one another. When you call 911, you get police, fire, or ambulance. When you call 988, you speak to a crisis counselor. So if you want to talk to a crisis counselor, call 988.
Yeah, I think, and we've talked to a lot of different community members as part of like projects doing surveys with small businesses, with neighbors, and they really do want to know like how to help their neighbors and don't know anywhere else to call, but 911. And then I think that, and we'll probably go into this more, and this goes to Councilmember Lee's bill as well, is that a part of the problem too, and part of the education of not just knowing about 988 is knowing how to be a good reporter. Like when I went to Portland to check out the street response team there, I got to stand in dispatch just to hear how they were taking in calls. And like I had heard from and read in different reports about how the dispatch system, and now I'm talking about a 911 call for an alternative, but how like there's so many problems with it in terms of the coding and all this. But then after talking to the call takers, it was actually, it's much deeper than that, and something that can't be accounted for just in terms of codes. It's like, well, we have a legal mandate to take the information as it's described to us, and the people who are describing are not the best reporters, or they don't characterize behavior in a way that allows us to do the thing. And so I think that continues to be like an incredibly important thing in addition to people knowing about 988 is like knowing how to talk about people who are in crisis.
I think that's an important point. I think there's some distinction, right? 911 is taking callers at face value. Whatever they're saying, they're not probing further.
Yeah.
The volume is high, and they need to move through those calls quickly for emergency services. 988 counselors are probing. They're listening, asking open-ended questions. So I don't expect a New Yorker to know how to make a good 988 call. I would never put the burden on the public to know how to make the call. That's the counselor's responsibility, is to ask the questions to get the information that's needed.
No, I hear that. That makes sense. I think as somebody who lives with a mental health diagnosis and loves a lot of people with a mental health diagnosis, like I would just while it might not be my burden, like I want to have more tools in my toolbox. I want my neighbors who care for me to have more tools in their toolbox when trying to get me help. And I think that's like a really good thing to build like that muscle as a community, and if government can help with that, like even better. I'm going to turn it over to, oh, did she leave? Do you have questions? Yeah, go for it.
I have a question about the mobile crisis team, and you operate between 8 a.m. and 8 p.m. What happens in that 12-hour gap? And, is there a plan to extend those hours beyond 8 p.m.? Because as you know, mental health crisis can happen at any time, any day. So that's basically my question.
And what do you need to be able to operate?
Right.
Yeah, this is an important question and one we've thought about a lot. And in fact, we went through a procurement process in 2019, just before the pandemic, in an attempt to procure overnight mobile crisis response. We didn't get any bidders. I think we got a lot of feedback from the provider community that even with the higher funding that we offered for overnight, there were concerns by providers about safety. They're typically, two people traveling in their own vehicles, maybe in public transportation, getting into buildings, going into apartments unaccompanied is a risk for them during the daytime, and they do great work, not from the client necessarily, just being out in the world. And so the providers were really concerned about safety. And we explored, security with them, didn't love that idea, but, would that work? But we do see fewer calls coming in overnight. And so the 988 is open, right? They're providing the telephonic crisis counseling overnight and making a decision based on the services that are available at that time. Often the person may say, you know what, if I can be the first referral in the morning for the mobile crisis team, they get out there by 9 a.m., 8, 9 a.m., that's okay. It's going to be fine. If it feels like it's unmanageable in that moment, we'll talk about going to a hospital. Our city has I think maybe about 15 comprehensive psychiatric emergency programs, right? Robust, site-based, hospital-based psychiatric treatment 24/7 in those CPAPs. People can take themselves there. I've walked into an emergency room, we can all take ourselves there. If it's not, if that's not going to happen, if they're not going to take themselves, then they will, engage in emergency transport to the hospital. Request, the police or ambulance to respond overnight.
Okay. No, I mean, I myself have been, involved in a situation where, family member, having a mental health crisis, unwilling to call 911 because did not want police intervention. Person was uncooperative in terms of, trying to talk them down from the crisis and getting them to a hospital. So it just, I just think that, having a mobile crisis team that's available, and also, just the training that police officers and even EMTs receive is inadequate to deal with certain situations. And so that's my concern, that, there's a 12-hour gap where someone could be in crisis. A neighbor, a family member, may be calling to try to help that person and is unable to do so on their own. And, EMT and police intervention is not, is much less than ideal in certain situations. So, I just want to express that concern. And if we could figure out a way to, expand the services, or even have crisis specialists embedded in NYPD or EMS, the FDNY, to help those types of situations.
Absolutely. I think we'd love to explore those options, right? We want to be,
Thank you.
we want to protect the safety of our staff and the people we serve, right? And find the best approach to do that.
Good. Okay. Thank you, Councilmember. I actually want to expand on that a little bit. You said that the falls call overnight. Can you give a bit of a comparison in terms of like the percentage of drop, or just, is there anything?
I'd have to get greater detail.
Yeah. Could you follow up with that? I think that would be, I think that would be helpful. And, I certainly understand the challenges around safety and things like that, but and this is something I'll ask about a little later on, but I think that also has to do with sort of like career pipeline work and who feels comfortable being a street worker and who doesn't, because it's not for everybody. Like I spoke to the founder of the Denver Star program who is an EMT worker himself. And he said, the big thing is making sure that we have a pipeline of people who want to do street work. I was a public defender. We worked with social workers. They're forensic social workers. They want to write the reports. They want to do the interviews. They don't necessarily want to be doing street, like there are all of these different kinds of ways to practice the profession, and street work just isn't for everybody. Like you can't, some folks are going to walk into a different neighborhood, a different context, a different situation and be uncomfortable. And some folks, we good, right? And so like just what the work that it takes to be able to find those folks that are like built for that kind of work, I think is incredibly important, and they exist.
Yes, yes, they're doing heroic work right now.
Absolutely. Okay, I think, where should we move to? Yes. I guess how many calls to 988 result in a mobile crisis team dispatch, and what share of the dispatches successfully reach the individual in crisis, and sort of average response time? But I want to give a caveat here, because I actually am not always so concerned about the response time depending on the situation, and if it means that you get to avoid a police officer coming instead. And some of the numbers that I've seen is that even if the response is a little bit delayed, that there's not much different in the percentage of times that they're able to reach the person. So I'm like, well, if you're I'm making up a number now, if you get there within 20, 30 minutes and the person is still there 30% of the time, and also if you get there an hour later, hour and a half later, and still you're getting to the person 30% of the time, and it still means that you didn't get a police officer, I actually prefer, there are difference of opinions on that. I'm like, yeah, okay, great, I'll go with that.
Yep.
So I'm asking that question, but like with that caveat, I'm just curious about what the numbers are.
Yep. So I think you make important points. 988 makes about, it was about 9,000 mobile crisis referrals last year, or assignments, dispatches. I'm sorry, I'm using those words interchangeably, although I shouldn't. That represents about half of the volume that mobile crisis teams handle, because while half of their referrals come from 988, the other half come from within the hospital provider's own network. So for example, if I'm Bellevue Outpatient Clinic and I'm worried about my client because he left me an unusual voicemail, I will refer to my Bellevue Mobile Crisis Team. I won't dial 988. That's right, they're the same electronic health record. And in that case, the Mobile Crisis Team has a lot more information about the person, right? Because it's somebody that's in their care, right? They have a health record. They may know their schedule, collateral context, and they may time their visit, right, to be optimal, right? What does that mean? When the person will be home, maybe when there's like a family member there who's helpful, or maybe when there's not a family member there who's not helpful, right? So they're going to handle the timing based on their own, they're going to triage that timing themselves. Whereas the 988 calls, we say, these are all going to be, you're going to get here as fast as you can, because you have generally less information than you would from within your hospital system. Yeah. So those are the ones that are averaging within 2 hours.
Okay, got it. Thank you. I'm gonna move over to SPOA. Who can submit a SPOA request? What information is required, and sort of walk us through what a referral submission actually looks like from start to finish?
Oh, wow.
These are big questions.
That's a lot of detail. Sure. So the single points of access were established in the early, around year 2000 by a governor's initiative as ACT teams were growing statewide. The state was, opening up new ACT teams, and there was a recognition that there needed to be more coordination and organization within counties and the city of New York to centralize referrals and prioritize access. And so the single point of access was created at that time and has been operating ever since. Back then, it was just care coordination and ACT. Over the years, we've developed new subtypes of ACT, right? Forensic ACT, Shelter Partnered ACT. We developed IMT in New York City. We've doubled the capacity of SPOA accessible services in the last 10 years. It's grown substantially. The SPOA is still, though, a subset the larger mental health system. Most people get their mental health care from licensed clinics, and of which we have many, and those are accessed sort of directly. But the SPOA pathway is typically for folks who have not engaged in clinic treatment and really need somebody to come out to them in their home and proactively engage them, either at the care coordination level or at the sort of whole treatment team level. So both of those options come in. Our referrals come about, let me look at the numbers, 58% of them come from hospitals, right? 30% from private hospitals, and 28% from Health and Hospitals Network. So that's the biggest single source of referrals as a part of a discharge plan from an inpatient stay.
Yeah. Who else can refer, though? Like, obviously, we know corrections can refer.
Yep.
My office has referred.
Yep.
Like, who?
Anybody can
be-
technically refer,
Okay.
right? Can go into our system and complete an application. We're looking for also a psychosocial assessment or a psychiatric evaluation to say that this person, in fact, would benefit from this kind of care. But technically speaking, anybody can refer. Practically speaking, it's mostly coming from hospitals, state psychiatric centers, Department of Homeless Services, correctional health services, outpatient treatment providers, right, who are stepping a person up, as well as supportive housing providers.
Yeah, I'd be curious if you all are interested in sort of building out a plan that with a metric or a goal being that you're seeing more referrals from outside of the hospital setting. Like I said, we've done, just as a discrete example, my office did like a survey of 200 plus small businesses about safety issues and what they're seeing, whatever. And they just they would be happy to do referrals if they sort of understood, because they're seeing the same people every day, or they're concerned about it. And the less people that are going, we just saw the nurses come back from being on strike, and the biggest thing was the safe staffing. Like, you have people that are going into an emergency room, and the setting to which they're going into, especially if they're shuffled into like a psychiatric response department, is like, I mean, it sucks. It puts everybody in a terrible position, and it's not like a therapeutic environment, just because of so many of there's a lot of work to be done there.
Yeah.
They need a lot more. Bellevue needs more money.
If I could take a moment there just to sort of touch on that point about community members, right, making referrals. Absolutely, we can talk about that. I think that's also a reason, a driving force behind our Connect Clinic pilot, right, where we've built these enhanced clinics that have a community engagement component, right? A full-time community liaison who's talking to local businesses and communities to help get the clinic sort of go bust out beyond its four walls and be sort of more of a resource to community, responsive to community needs around food insecurity, around, childcare, legal assistance, right? Whatever it is that it's important to that. And that is also a great resource for local, local constituents, right? Just general New Yorkers to connect with those. And that
anything
may be
we
more
can do
achievable than
to be able to like take that information to our constituents. I think
great.
we'd be happy to do so.
Awesome.
When a referral is submitted, like who reviews it, and what's the criteria for determining eligibility, and how long does the review usually take?
Sure. So there's a team in my Bureau of Mental Health of clinicians that review these applications within 2 business days. They're reviewing them very quickly and making a decision about level of care that's appropriate. Looking at diagnosis and hospitalizations or incarcerations, as well as what else has been tried previously.
Yeah, and if what happens if a referral is denied? Is there an appeals process? Are there other options available?
Yeah, so I think we got 4,952 referrals last fiscal year. 4,654 people were connected to care, right? So the vast, vast, vast majority of folks are getting connected to care. And it may not always be the higher level of care, right? They may be connected to a care coordinator, as I mentioned, as an alternate level of care while awaiting a higher level of care. But the vast majority of folks are eligible and assigned to either a care coordinator or a treatment
And
team.
let's say that the referral finds it appropriate to like for an IMT or like an ACT team, but there's a wait list. What happens during that period of time?
Sure. So they're offered the care coordination while awaiting the higher level of care. Some folks are also transferring between levels of care on that wait list, just in case if a person, I live in Queens and I relocate to Brooklyn, I'll get online for a Brooklyn-based team. We wouldn't prioritize that, honestly. That person we'd wait a bit because there's other folks with higher priority who are not connected to any care, right?
Yeah.
We would assign those first. And so that's how we manage the wait list.
Okay. Yeah, that's what I was going to ask. So before I ask that question, one question I have is, this is like a bureaucracy thing. Like, do you find that there's a challenge or a problem with, you're getting referrals and you get a referral from a hospital and a shelter and DOC and they're for the same person? Like, how are y'all navigating? Like, how's that reconciled?
Sure. So you're talking about the data deduplication. Woohoo, we could talk about that all day. That's a challenge. I think the chances of that happening all at once are low, right?
Yeah.
Because the person's in one place. It's going to be either correctional health services doing a discharge
it's not going to be correctional health and a shelter.
Yes, but the chances that person maybe previously had been referred to SPO and already had a record in our system, we would merge those records, right? So that we can see the full history.
Yeah. And then, and this is something I came across as a defender trying to get my clients into programs. So is there a gap in sort of referrals or people who are struggling in terms of having like a dual diagnosis? Because so often somebody gets a referral and they're like, on a lot of different fronts, they're technically eligible, and then the provider finds out, oh, this person has a dual diagnosis. We can't accommodate that. We can't handle that. Like how often are we seeing that?
Sure. So the term dual diagnosis can be used for, a number of, co-occurring health and mental health and substance use conditions. So you may be referring to co-occurring mental illness and substance use. We also have co-occurring mental illness and developmental disabilities, right? And so there's a variety of things that we see. All of our SPOA accessible services will serve and provide care to people with co-occurring mental illness and substance use, right? That is never an exclusionary criteria. We have concerns about co-occurring mental illness and developmental disabilities. ACT is not a good level of care for those folks. And so that's a challenge. And so some of those folks will go towards IMT, right? Based on that maybe they have a developmental disability and substance use, for example, right? That wouldn't fit into the typical ACT bucket, but would make sense for IMT.
But I guess my question beyond that is that do you find that that's a pain point? Is there room for improvement in terms of some difficulty placing folks that fall into those categories?
That fall into the co-occurring mental illness and substance use?
Any co-occurring, like just in terms of the rate of being able to be placed quickly on an appropriate team or connection.
I think what we're seeing most, the bigger gaps, and one of the reasons we created IMT in 2016 is for unclear sort of neurological or cognitive conditions, things like traumatic brain injury from repeated falls, perhaps, or substance use, or unknown causes, or developmental disabilities, right? That group of people, their behaviors or symptoms may manifest as sort of mental health, but the etiology may be different, and so diagnosis is unclear. And so that's an emerging need, and a lot of those folks, that's why we created IMT, to fill that gap.
Well, yeah, and just again for the record, in terms of like the IMT being the most flexible of the teams, because you're not getting the Medicaid reimbursement and have access to just doing things a little bit differently. Is that like a fair characterization, or?
Yes, and it's a slightly different group. It's not the sort of neatly sort of packaged diagnoses. It's where things are more complicated or confusing. They have the flexibility to say, hey, let's while you go to this TBI sort of program, we're going to stay with you, right? And we're not double billing in that case. It's okay.
Makes sense. Councilmember, do you have? I'm just like, do you have any more questions? You just like tap me and let me know. Okay, all right. Okay, so I yeah, I was gonna skip that. I'd love to ask a little more detail about IMT versus ACT versus SPACT versus FACT. It's like all the letters. Oh, do you want me to do that one? Yeah. Okay. Wait. This is the boss over here.
I got some. Thank you.
Before I do that, providers report that SPOA sometimes assigns individuals to teams in the wrong borough. And you talked this too about also the other occurrence where like if somebody moves, but like also if they start their contact in one borough, they get assigned another borough, and that results in longer waits while individuals get reassigned or force individuals to start care with one team and then transition to a second team, raising concerns about continuity. Are there processes that you're looking into to better assign individuals to the appropriate teams at the onset, or is that just simply a capacity thing where you got to scale, or yeah, what's your assessment of that?
So I mean, first, tell those providers to call me. We can talk. I don't know exactly what I haven't heard about that complaint specifically. I can say for sure that the SPOA is working to get a person connected to the team that covers where they live.
Yeah.
People move, and it's possible that they moved. I'm not sure that's not a sort of systemic
Well,
issue.
and
that
it's
I've heard of.
I will say it's something that's been brought to us several times by cases. So I think that might be a good place to start, touching base with cases, because I don't think they're talking about like when an individual moves, but just simply when they're being connected to care and it's in another location. Okay, now I will go over to the other teams, but I think you guys talked through the differences between IMT and ACT, so I won't ask that. If somebody qualifies for both IMT and ACT, like who decides which program they go to and on what basis?
Sure. So I think we would. There's a clinician at the single point of access who's looking at the person's information and the referral source. They may speak with the referral source or somebody who's in contact with the person and figure out what makes the most sense. It's maybe about availability. And typically, right, IMT is there's fewer spots of IMT than there is for ACT. And so if a person qualifies for both IMT and ACT, I think we would default
probably
towards
gonna get
ACT.
ACT.
Right, yeah.
Yeah. Okay. So it's based on capacity, not necessarily where like a designation on like actually this would be the most appropriate or.
I mean, it's really hard to answer that. I mean, they're going to make the most appropriate service. There's certainly an overlap in eligibility criteria between ACT and IMT. The Venn diagram, there's a bit of a Venn diagram, and those folks, I mean, you're going to make an individual decision.
To be clear, I'm just trying to make the record that you guys need way more resources. So.
I'm always pleased to make that point.
Okay, for SPACT, for people who are shelter system involved, can you talk a little bit about what's different about serving someone in shelter versus in the community, and specifically how SPACT adapts to that setting?
Sure. So the Shelter Partnered Act teams are licensed by New York State, and they're actually contracted by New York State, but they're accessed through our SPOA. And so I don't want to take responsibility over those teams, but I certainly do, know a lot about them because they're sort of a part of our healthcare system, and we work so closely with the state. And they have relationships with the mental health shelters with which they work, which are important, right? Because shelters are closed, right? Not just anybody can walk into a shelter,
right.
And there's also the person. Certainly, people who are experiencing homelessness are served across our healthcare system, but it's like 100% of that Shelter Partnered Act team. So a focus of their work is housing placement as well. So they have the resources and relationships to get into shelter and to focus on the housing placement in addition to the standard ACT package of mental health and substance use related services.
Thank you. I want to talk a little bit about justice-involved folks. So for a FACT team, like at what stage of criminal legal system involvement is a FACT referral appropriate? Is it pretrial? Is it post-conviction? Is it reentry? Is it all of the above? Is it we're trying to get in there as early as we possibly can?
All of the above, right? Any sort of criminal legal involvement coming out of state prison, out of local jails, on probation or parole, right, or in some sort of a diversion program. They're not. It's a broad definition.
Is there, when somebody's going, so if we want to try to do it at the earliest possible juncture, one of the most critical parts of criminal legal system involvement is the arraignment, right? Because that's when the judge is going to make a determination as to whether a person is incarcerated pre-trial or not. And is there any possibility of being able to have even short pre-assessments in arraignments so that an attorney advocating for somebody is able to say hey, this person qualifies. We can get them on a list for a team. That's a reason to release them out into the community. I know that, attorneys are doing that for a host of other things, whether it's cases that's in arraignments that day or another provider. But yeah, curious if you see that as being possible or something that can be worked towards.
Yeah, I mean, I can say that the health department has recently is standing up a mental health navigator program connected to the courts in partnership with the State Office of Mental Health. I think that program is still sort of getting off the ground, and they will focus on that sort of situation that you're talking about.
Yeah, that moment where bail is set is the most disruptive in terms of any sort of connection or continuity of care. And then, we also know what's happening inside of Rikers to folks who are struggling with these issues. Yeah. Okay. Oh, yeah, we can do that. According to the State Office of Mental Health's data, many ACT teams in New York City are operating at 90 to 100% capacity or above. What's the plan to expand capacity to meet demand, and are there plans to contract additional teams? Those are good numbers. We want more.
Yeah. So as I said, the capacity for mobile treatment services, including ACT, FACT, SPACT, and IMT, has doubled since 2016. That most recently, right, with the 2 FACT teams opened up. So that's new forensic act capacity through state RFP, right? But those were accessible through our single point of access in the city. The state also did a procurement for Flex Act teams to address the issue of step down from Act. And so there's 4 that were awarded in the city. A typical Act team has a capacity of 68 people. These Flex Act teams go up to 100, with those extra sort of 32 people being sort of folks who maybe get less frequent care. And so the idea is you can expand your caseload if you're seeing people a little bit less, and there's some more funding that comes in for that as well. So that funding comes through us to those teams. So that capacity has already been added as well.
And I think that's also part of the funding that we won last year in terms of being able to expand sort of the step down.
Yep, exactly.
Okay. I want to talk a little bit about racial disparities. The ACT data is showing that 55% of participants are Black. And so I'm wondering what culturally responsive practices are teams using? How is DOHMH ensuring that those practices are consistently implemented? And then not just that, but also, what is the training, the cultural competency for also trans and gender expansive folks?
Yeah, so we see those, we see an overrepresentation of Black and Hispanic New Yorkers across all of our adult mental health services. Typically up about 75% of folks identifying as Black or Hispanic in our care. And what is driving that, right? And we look at the upstream referral sources, and the disparities in inpatient hospitalizations by race are similar. Racial justice and health equity are sort of core components of all of our work. We have a number of collaboratives with our providers to talk about how they can promote racial justice and health equity within their programs. We released guidance a couple years ago and have including things that organizations can do to address the work in terms of board representation and pay parity, and then also trainings for race conscious and trauma informed care at the point of delivery, and then of course looking at outcomes as well, as see if those disparities exist at outcomes.
Well, thank you. Move over to Be Heard, and then we'll go to the next panel and following that public testimony. So Councilmember Schulman isn't here anymore. I appreciate the work that you're doing. I want to push a little bit, though, on sort of the concerns around increasing reporting.
Yeah.
Because, and to put this into context, right, like, there are a lot of things that Be Heard is doing well, and then there are obviously areas for improvement. I know that our colleagues are constantly talking about the percentage of calls that are eligible that get answered by Be Heard, and while it might seem low on its face, it's actually in line with the national percentages of these other programs that are doing well and responding to as many as they are, and they're saying, like, we need to scale also. The difference is they're getting better outcomes. They are. They're calling the police in less. They are making better connections, and that's like the where do we take people? I think Be Heard will never be the success we want it to be unless we have more places to take people. Period. But I will say that, and the last time there was like that big multi-agency hearing on Be Heard, I had asked a lot of these questions. But in terms of data and being mindful of HIPAA and all those things, I've got the Cahoots quarterly report, the Portland Street Responses quarterly report, Denver Stars quarterly report. It's really long, and they're collecting a lot more data, and they're not violating people's HIPAA rights, and the data that they're collecting is allowing them to get better, more effective outcomes. We get the reports from Be Heard, and they're like 7 pages long. I mean, this is Be Heard's. This is the Denver Star Program's report. And so I just want to push us, because we are going to continue to sort of underperform in terms of outcomes if we don't start getting that data. Like, it's really, really critical. And so I guess a question I have for you is, have you all looked at the data that these other programs are keeping and gone through each of the categories, and not just data on individuals, but like, we're not even keeping good enough data on the geographic information, like where are the heat zones, where the times of day, the breakdown of the types of calls. I don't think that there's anything precluding us from doing that. And we see it. Like, this is amazingly not a new thing anymore. So many municipalities have this alternate responder. They're doing better than us. I want us to do better. And I think data is a big part of that.
Yeah. Thank you for that. So under the last administration, our cadence for reporting data on Be Heard was essentially kind of close to annually. We think we can do much better under this administration. We think that we can make more data available. We 100% agree with the spirit of Intro 722 to be able to report more data more frequently, potentially on a quarterly basis. And so we look forward to working through that and to being able to be able to share and publish more data. I will say one of the complicating factors that we have here in New York City compared to a lot of these other programs, which we do have contact with. We speak to Denver Star.
I know.
Okay. Our 911 system is dually operated by NYPD and FDNY, and then Be Heard is also introduces, a third entity, which is H&H, which is why under this administration, we are deeply focused on interagency coordination and really figuring out how to be able to bring agencies together to work more cohesively and be able to share information better.
I believe we can do it.
I think so
The
too.
challenges in different places are different, and they're they're addressing them. They might be different than New York City, but it's no different the existence of a challenge of, say, like a municipality that says, well, our responder isn't a city employee, and so that poses its own kinds of challenges.
Yep.
They're problem
Yes.
solving for different things too, and so I just want to say that, like, complete partners in that. We want to be at the table for that. I don't want to step on Councilmember Schulman's toes in terms of her leading on this bill, but like anything that we can do to help
Yes.
along with this, like we're here for. I'm certainly here for. That's what I had for you. Do you have a question? Okay, beautiful, and then you can end us.
Yeah,
All right.
Yeah, I just want to go back to the equity question and access, and how are 988 IMT and ACT services being made accessible to undocumented New Yorkers who fear, naturally, especially nowadays, fear contact with government agencies.
Yeah, so 988 is anonymous.
Okay.
Largely, right? If there's a mobile crisis rule, we need some more information, like your address, so they can find you. But the vast majority of people who reach out to 988, as I mentioned earlier, are just getting that immediate telephonic response, and so their immigration status is not relevant to their call. They're able to access it as much as they want. Their distress may be related to their call, and we can talk about that, but they're not going to need to, obviously demonstrate that they have, what their immigration status is to receive that service. It's available across the board. And for our SPOA accessible services, those are all available to people with and without insurance. There is no insurance requirement or documentation about ability to pay or immigration status that factors into our assignment.
Yeah, I think that, accessibility also requires a level of education and dissemination of information to our communities. Many communities don't know that they could access, 988 without fear of, being, singled out as being undocumented or so that's a big concern in many of our communities. And how do you address that?
I mean, that's certainly something we can reflect in the campaigns that we're planning. Dr. Wright mentioned that we're planning 988 promotion campaigns, and that's seems like an important sort of focus population of at least some part of that public education effort. It's a good idea.
Can you give any detail on the, because that was mentioned in the testimony too, of like these campaigns you're planning over the next year? Are there any plans drawn? Like, what do they look like? What are they?
There are plans. I can't give detail on them. I think just because I'm not the comms expert, I was focused on the program.
That's something that we would love
expert,
to get follow up on as well. Awesome. Those are my questions. Yeah. Okay. Those are my questions for you guys. Thank you.
Thank you.
Yeah. Thanks. Can we take like 2 minutes?
We're going to take a 2-minute break before moving to our next panel.
Are we good? All right. Welcome back. No funny business. I don't have time for that. All right. Thank you, Councilmember Felder. Before moving to public testimony, we're going to hear from a panel of individuals from the Independent Budget Office. So welcoming up Ed Dowen and Cassandra Stewart. Hi, welcome. Okay. I hear you want to be sworn in. I dig it.
I will now administer the affirmation to the witnesses from the Independent Budget Office. Please raise your right hand. Do you affirm to tell the truth, the whole truth, and nothing but the truth in your testimony before this committee and to respond honestly to council member questions? Thank you. You may begin when ready.
Good morning, Chair Caban and members of the committee. I'm Cassandra Stewart, Lead Budget and Policy Analyst on Health at the New York City Independent Budget Office, IBO. I'm joined today by my colleague Ed Dolan, who is a Senior Policy Advisor at IBO. I appreciate the opportunity to discuss some of the findings of IBO's January 29 report on the Behavioral Health Emergency Assistance and Response Division, BHERD, with you today. The report focused on BHERD operations and identified several factors that should be considered for optimal performance, both for the current program size and if the program expands. A companion report focused on precinct-level data. IBO's report explores BHERD as it has been structured until now. A program jointly funded, operated, and staffed by the Fire Department, FDNY, and Health and Hospitals, H&H. IBO conducted its analysis using FDNY data from the beginning of the program in June 2021 through the end of March 2025. Key takeaways from the report include, as far as eligibility, the number of calls deemed eligible for a BHERD response increased 9-fold between the first full quarter during which the program was operational and Q3 of fiscal year 2025, which is the last period that IBO has data for. While a greater share of calls has been deemed eligible for a BHERD response, consistently more than 40% since the third quarter of 2023, a declining share of eligible calls have been assigned a BHERD unit, down from nearly 80% at the beginning of the study period to 37% by the end. In terms of response time and time spent on scene, IBO's analysis reveals that the response times are slowing, not just for calls eligible for and receiving a BHERD response, but for mental health calls citywide as well. At the beginning of the study period, the median response time for BHERD units was 12 minutes, while at the end of the period, this had grown to 21 minutes. In the most recent period of data, the third quarter of 2025, the median response time for non-BHERD units was approximately 19 minutes, which is slightly faster than it was for BHERD units. BHERD teams typically spend a longer time on site than other teams responding to mental health calls, which indicates that they're taking a longer time to evaluate and resolve the cases once contact is made. In the most recent data on hand, the median time spent on scene for calls receiving a non-BHERD response was 19 minutes. For calls receiving a BHERD response, the median time spent on scene was 33 minutes. With regard to staffing, as the area covered by the program has expanded, the number of teams has also grown, though not at the same scale. BHERD began operation in 2021 with 2 teams per shift, expanding to 3 teams by the end of 2022, and then 6 by the end of 2023. By the end of 2024, with 31 precincts covered by the program, there were 9 teams operating during each shift. This was also true in 2025. As the Mamdani administration moves toward developing its Department of Community Safety, this research provides unique insight into mental health calls, BHERD teams, the timing of BHERD responses, and geography served. Additionally, as there have been calls by council members and advocates to expand the program citywide and to extend hours of operation 24 hours a day, IBO's report identifies operational challenges for consideration. BHERD is still considered a pilot, though it's been operating for more than 4 years and currently serves approximately 40% of the New York City population. As the program has expanded, response times have slowed. This may be in part attributable to the program's expansions outpacing the scaling of staff. Looking ahead, if the city chooses to proceed with the current program model, officials might consider what staffing levels are optimal in order to meet current demand levels in terms of the volume of mental health calls received. If the city moves forward with the Adams administration's proposal to shift BHERD to H&H's sole control, factors such as call routing without FDNY involvement, replacement of FDNY staffing, and contracting for emergency vehicles are all issues that will pose operational challenges if not addressed. Thank you for the opportunity to testify, and we're happy to answer any questions.
Thank you. I think I'm just going to start. Also, I want to acknowledge that I do still see the administration in the room, and so thank you for staying and listening to some testimony. It's appreciated. I want to start where I ended, actually. I obviously pressed the administration some on some of the concerns or hesitancy around collecting and compiling and publishing more data points. You, in your report, you point out some of the pain points, some of the areas of growth. Do you think that being able to get that data, analyze additional data, would help address some of these pain points and the efficacy of BHERD as a response system?
That's a great question. I think it's important to be able to look back at the few years of the program that we have now, analyze data that we have on hand, and see what's working and what's not working, and use that to inform how we go forward.
And you mentioned that 4 years later, this is still a pilot.
Yes.
I think we've gotten to a place, and we have enough information to know that this should be a permanent part of our continuum of care. Obviously, with the goal being that BHERD is successful if they are, through their connections to care, not just reducing and like getting somebody out of crisis in the moment, but that they're actually reducing the number of calls, as a result, reducing the number of calls that come in generally. Can you talk a little bit about Can you talk a little bit about sort of the challenges that get posed in terms of when it isn't scaled properly? Because you started to touch on that. I think that's important.
Right. So what we found in our research is that at the beginning of the pilot in June of 2021, the program was launched in 3 police precincts, and there were 2 teams operating per shift. And currently, or at least as current as our data goes, there were 9 teams operating per shift in 31 precincts. So we scaled the number of precincts that we're operating in, and then the number of teams operating per shift didn't grow in accordance with that.
Thank you. And I think I'm going to make an analogy here, and you can tell me if this sounds right to you, but one thing that has been said in the violence interruption space is that, to your point that you testified, is that we get good outcomes, and then what happens is they're asked to cover more turf with not more resources, or like not the commensurate resources. So then you take a crisis, like you take a violence interruption group that reduces gun violence in their catchment area by 90%, but then you ask them to double their catchment area and you give them 10% more resources, and now they're reducing gun violence 30%, which saving lives, that's great, but like it is undercutting the efficacy of the program. And then that's how things stay pilots, because you're like, well, it's only part of the solution. Like, we're not getting the best results we can when we know actually we could be getting a lot better results if we do it properly. Do you think that that's sort of like a fair kind of analogy to make in terms of how we should think about BHERD being scaled?
I think that mirrors what we have put forward in our testimony. And I think it's one of the considerations that we put forward in the report, is that we do need to, or city officials need to consider what the appropriate level of staffing is going forward in order to meet the current level of demand. And if there's increased demand going forward, what that appropriate staffing level would be.
And I mean, the current staffing includes, an EMT. I don't know how we're supposed to keep these folks when we don't pay them. We don't pay them. they don't stay. The EMT as a workforce spends all this time training up these folks, and then they lose them after 5 years, and they go to another emergency response. When you talk about the challenges of being able to fully staff and then scale, do you see that as being part of the problem?
In the report, we do give specific numbers as of the last fiscal year for how many social workers and how many EMTs are working with the program. So at the end of fiscal year 2025, there were 34 EMTs working with the program. And sometimes those EMTs do get lost to transfer to other departments, or they might find new work or something like that. We do discuss in the report the challenges that the city has had with hiring and retaining social workers.
Yeah.
But we also note that the health and hospitals has made efforts to recruit and retain in the most recent year.
Yeah, these folks are not getting paid enough to do this work, clearly. I want to. Y'all were way more successful at getting data out of these agencies than we have been. So I also, because you were able to you said you conducted the analysis using the FDNY data from the beginning of the program in June 2021 through the end of March 2025. How long did it take you to compile this data? And like, did you have to go to different, how did you do it? Because we've been fighting to get this data.
That's a great question. Truthfully, IBO is uniquely positioned in city government because it's baked into the city charter that we can request and receive data from other city agencies. To answer the other part of your question, it did take about a year to pull it all together, but we got there in the end, and we did put out the report.
Okay, that's helpful. Is there anything? Yeah. I mean, also the floor. Is there anything else that you didn't get an opportunity to testify on that you think is worth putting on the record?
No, I think we covered the high points, and I would encourage everyone to read the report because there's good data in there.
Yeah, absolutely. Thank you for the work that you're doing. Those are my questions.
Thank you so much.
Okay. Where I put the script? Was it down there? Oh, I have it. I got you. Okay. We're now going to open the hearing up for public testimony. I want to remind members of the public that this is a government proceeding. Decorum shall be observed at all times. As such, members of the public shall remain silent at all times. The witness table is reserved for people who wish to testify. No video, recording, or photography is allowed from the witness table. Further, members of the public may not present audio or video recordings as testimony, but may submit transcripts of such recording to the Sergeant at Arms for inclusion in the hearing record. And if you wish to speak at today's hearing, please fill out an appearance card with the Sergeant at Arms and wait to be recognized. When you're recognized, you will have 3 minutes to speak on today's oversight topic. If you have a written statement or additional written testimony you wish to submit for the record, please provide a copy of that testimony to the Sergeant at Arms. You may also email written testimony to testimony@council.nyc.gov within 72 hours of this hearing. Audio and video recordings will not be accepted. And the other thing too is I know that this room isn't really designed for it, and there are advocates here and people from organizations, and you like to have a picture of you giving testimony. So if you would like that, just like hand the sergeant your phone, they'll hand it to me, and I'll take that picture for you. I know it's important. The people got to see the work you're doing. Okay. We're moving to panel one? Mm-hmm. So panel one includes Benjamin Heller, Jordan Rosenthal, Nadia Chait, and correct me if I don't pronounce your name correctly, Dr. Van Yu, and Danielle Regis. And you can start in whatever order y'all want.
go. Hi, everyone. Thank you, Chair Caban and committee members for holding this important hearing about how New Yorkers get connected to mental health care. And thank you to the administration for staying. I really appreciate it. So my name is Jordan Rosenthal, and I am a social worker, a peer, and the director of advocacy at Community Access and the lead organizer of CCIT NYC. I'm here today under my CA hat, and I'm going to talk about some feedback that I got when I spoke to our homeless mobile teams and housing directors about what they think is the most important thing for council to understand, what investments they want to see, and what other changes they envision. So really from this on-the-ground boots perspective of what they encounter and the problems. So staff emphasize that emergency systems and coercive measures like AOT are overutilized and do not address the needs of community members who struggle with their mental health. They described consistent system failures to support individuals who do not meet the criteria for longer-term hospitalization, but are hospitalized frequently and are already connected to ACT services. For some people, the lack of timely and comprehensive support services in times of crisis can put people at risk for interpersonal violence and behaviors that create fear and concern for other community members. When police are involved in these scenarios and bring individuals to the hospital, they're almost always discharged because it's a behavioral issue and not a mental health issue. Or conversely, due to administrative pressure in the hospital system and to reduce liability concerns in the discharge planning process, individuals are placed on AOT instead of connecting individuals to voluntary treatment and support options. In particular, when people are experiencing prolonged periods of crisis and threats or act of interpersonal violence or property destruction, Community Access has had multiple complex needs case conferences with the state and city DOHMH, which have produced no answers or solutions for where these community members might be referred to for real assistance or a safe place to live that will not endanger others in that environment. So when asked about what investments they want to see, they pointed to embedding higher levels of support in supportive housing. For example, funding interdisciplinary teams that could be deployed by housing providers. So like an internal type of IMT team that you could send to all of your different supportive housing sites and kind of have it 24/7 and not have to rely on an external actor. And including peers on these teams would be great value in terms of engagement and connection building. They highlighted the need for crisis response providers who can physically travel to meet people in their homes or places where they're comfortable. Supportive housing providers need access to more funds to have like multidisciplinary teams within their care, including RNs and psychiatric nurse practitioners. Okay, thank you. This would serve aging in place and isolated community members by lowering barriers to access to care. In turn, this would reduce unnecessary emergency room utilization, improve tenant health outcomes, and reduce mortality rates for already vulnerable populations. This sentiment was echoed by calls for expanding the IMT funding, specifically because it's not tied to Medicaid billing, so that way you can get people more services. So that's just preferred in that case. And then other suggested investments include lower density shelters, especially in the case of MICA shelters, the importance of decreasing wait times for mental health clinic access, and just the fact that people get discouraged when they have to wait longer. So really, as you said before, the need for having third spaces and options for people to deal with crisis and be connected to care in a timely manner. Thank you.
Thank you.
Hi, I'm Nadia Chait. I'm the Senior Director of Policy and Advocacy at CASES, and thank you, Chair Caban, for this hearing. CASES is one of the city's largest providers of intensive mobile treatment teams. We have 9 assertive community treatment teams, including 4 forensic teams and 2 that serve as an alternative to incarceration, and we have 7 intensive mobile treatment teams. So we fully believe in the incredible value of these services and the work that they do to help New Yorkers live their lives stably in their communities with the supports that they need. A clear priority for the city and this budget has to be, as you've discussed, eliminating the wait list for ACT and IMT. It remains unconscionable that we don't know the exact number, but some hundreds of New Yorkers are waiting for these services that they've been assessed to meet the need for And, I think often, and I think we didn't hear this today from the administration, which is great, we've often heard, well, folks get care management while they're on the wait list. But by virtue of qualifying for ACT or IMT, this is a person who needs a much higher level of care. And so really working to get folks into those services as rapidly as possible, and particularly making sure that folks who don't have an AOT order also have rapid access. And to that end, we also support the passage of legislation to require public reporting on the size of the wait list, so we have a better sense of the scope of that problem, and how long individuals are on the wait list, and if there are any demographic disparities within that. We also would like to see greater attention to reducing Medicaid disruptions, which can have a huge impact on people at critical times, both around hospital discharge and around release from incarceration. I'm optimistic with new leadership at DOC that we'll see more progress on this issue, but we've seen, particularly with our FAC teams, huge issues where people either actually are still having their Medicaid terminated, which should not be happening at all when people are on Rikers, or are coming to us with their Medicaid set to inpatient status, but without the appropriate documentation to allow us to get that status changed back to community. So their release paperwork is incomplete, they lack their vital documents, and often by the time we actually get that documentation, their Medicaid has become inactive, requiring an entirely new application. With IMT, that's not a barrier because IMT isn't a Medicaid service, but with ACT, it can present some real challenges, both for us, but also for referring that person across the continuum of care. And then the last thing I'll note is really on the workforce, and particularly with a focus on peers and building the career ladder for peers. So within IMT, we are actually able to fund peer supervision positions, which is really exciting for an agency like CASES that has a wide range of peers across our services. But we don't see that support for a career ladder for peers across the full continuum of services, and would like to see additional investments there. Thank you.
Thank you. Look at the timing. It's good. Plus cosign on peers. I do want to note that last budget cycle, the Progressive Caucus fought alongside community partners for the $15.5 million to expand the mobile mental health treatment teams and eliminate the wait list. And so that is a question that I will be asking at the upcoming budget hearing to see, how that money's being spent and what kind of progress we've made on it on that front. So thank you.
Hello. Hi, Chair Caban. Thank you for hosting today's hearing, and hi, everyone else. My name is Benjamin Heller, and I'm a program manager at the Vera Institute of Justice. Thank you for the opportunity to testify today. Our city increasingly relies on the criminal legal system to respond to behavioral health needs, and this has contributed to the ballooning jail population, hindering the city's commitment to close Rikers Island by 2027. As of last fiscal year, roughly 1 in 5 people on Rikers Island had a serious mental health diagnosis. Police, courts, and jails do not provide effective treatment, and incarceration often worsens mental health outcomes for individuals and for communities. To improve community-based mental health treatment, the city must start with 3 focus areas. First, and you've heard this a lot already, assess and scale existing services. The numbers we have are from March 2025, where the IMT waitlist was 672 people and the ACT waitlist was 682 people. City Council must pass legislation requiring DOHMH to regularly report on these waitlists, which will enable city government to make data-driven funding decisions. Expanding capacity will allow more people to access voluntary care, improving stability without resorting to involuntary hospitalization, arrest, or incarceration. Second, send trained peer specialists and clinicians to mental health crises, not police. Again, you've heard about this today. Be Heard's call triage limitations and narrow eligibility criteria have meant that in the third quarter of 2025, only 41% of, quote, emotionally disturbed person or EDP calls were deemed eligible for a Be Heard response. To close this gap, the city should update 911 triage and dispatch to make more EDP calls, including, importantly, instances of self-harm, eligible for Be Heard. Police should not be dispatched before EMS has the chance to triage a call. Strengthening training and support for call takers will help them better determine safety risk, and embedding behavioral health professionals in dispatch centers will further improve decision making. In addition, the city should add peer specialists to teams where appropriate, consistent with research demonstrating their effectiveness both in New York and across the country. And third, grow the behavioral health workforce. The city should mobilize a comprehensive behavioral workforce development strategy, leveraging existing assets like Health and Hospitals Peer Academy, Community Access's Howie the Harp, and other initiatives run by OCMH. This will enable the city to scale up mental health services to meet increasing need. And without it, even with adequate funding, services won't scale. Voluntary, community-based mental health services make our communities safer. By expanding and strengthening these services, the city can support people before a crisis pushes them into the criminal legal system. Incarceration cannot meet people's mental health needs, let alone do so with dignity or compassion. Thank you.
Good afternoon. My name is Danielle Regis, and I am a senior supervising attorney in the mental health representation team of the criminal defense practice at Brooklyn Defender Services. Chair Caban and members of the Committee on Mental Health and Substance Use, thank you for the opportunity to testify today on the critical issue of New Yorkers' access to crisis mental health care. As a public defender, I have represented people in Brooklyn's mental health court for approximately 8 years, and this month marks my 15th year as a public defender. The people I represent often encounter police when they are in crisis and seeking care, or when the absence of available care has led to the decompensation of their mental health. Too often, untreated mental illness becomes criminalized simply because the appropriate systems of care were not accessible when they were needed most. We are encouraged by the council's and the mayor's commitment to ensuring that people in crisis are met with care, not criminalization, including the creation of the mayor's Office of Community Safety. Mental health crises must be treated as health issues, not law enforcement matters. People seeking emergency mental health care must be met with the compassionate and immediate care to avoid escalation and possibly arrest. I would like to highlight several urgent issues that will help ensure greater access to care for people living with mental illness. We address these concerns in greater detail in our written testimony. First, New York City must increase access to safe, permanent, and affordable housing. When unhoused people are trying to survive on the subway or in the shelter system, accessing consistent physical or mental health care is often impossible. For many of the people that I represent, connection to stable housing has been life-saving. Basic stability allows meaningful engagement in care, but access to supportive housing should not depend on criminal legal system involvement. Second, we must expand low-cost mental health and substance use treatment. Many of the people we represent have tried for years to access appropriate care, but face significant barriers. For people with co-occurring serious mental illness and substance use needs, there is currently only one long-term inpatient treatment facility in New York City that actually accepts Medicaid. As a result, many people remain detained on Rikers Island awaiting a treatment bed. Jails should not function as a waiting room for care. We need a full continuum of treatment options for people who are ready to engage in care. Finally, we urge the council to support the Treatment Court Expansion Act. Judges currently have discretion to divert cases involving substance use disorders, but diversion for people with serious mental illness often requires prosecutorial consent. This leaves many individuals in traditional court where their conditions worsen. This bill would expand eligibility to people with other mental illnesses, developmental disabilities, and cognitive impairments that can be effectively addressed through treatment. Thank you for your time and attention.
Thank you.
Good afternoon. Chairperson Caban and other members of the committee, we thank you for this opportunity to testify. I'm Van Yu, the Chief Medical Officer of the Center for Urban Community Services, CUCS, whose services include mental health care via mobile teams, including city-funded street outreach and intensive mobile treatment teams, and state-funded safe option support teams. I'm here to advocate for measures to enhance the effectiveness of intensive mobile treatment teams, IMT. A significant proportion of New Yorkers with acute mental health needs, especially people experiencing homelessness, not only face access barriers to care, but also encounter care in traditional healthcare settings that is not well suited to their unique needs. Mobile teams not only address access barriers, but also bring expert providers who operate with flexibility and creativity, allowing for painstaking relationship building and effective care. IMT was created to leverage this flexibility, creativity, and targeted expertise to serve people with the most complicated mental health conditions who have been failed by other systems. These ingredients have resulted in the great success of IMT. Last year, there was a 38% increase of CUCS IMT clients who became permanently housed. Furthermore, CUCS IMT psychiatrists are able to engage people in treatment at higher rates than achieved in more traditional healthcare settings. About 90% of clients referred to CUCS IMT psychiatrists remain engaged in care. About 50% of clients living with schizophrenia adhere to long-acting injectable antipsychotic medications, and about 50% of clients living with opioid use disorder engage in medication-assisted treatment. Although IMT has been very effective, there are, as you've heard, wait lists of people who could benefit from the service but instead remain inadequately served and suffering. We encourage the city to move forward with plans to fund additional IMT teams. We also encourage the city to consider ways to empower IMT teams to influence where people are placed in safe havens or shelters, as the ability to place people in familiar neighborhoods or close to care providers can significantly improve engagement. We also encourage the city to consider ways to prioritize IMT clients to safe haven and permanent supportive housing placement to reduce the time to housing for this most vulnerable population. Finally, for the 10 years since IMT launched, CUCS has developed best practices that could support model fidelity and effectiveness across the teams citywide. We therefore also recommend investment in a centralized IMT training and technical assistance institute to promote shared learning, strengthen workforce capacity, and ensure consistent delivery of this high-impact model as it expands. Thank you for your attention and consideration.
Great, thank you. I just wanted to kind of, well, I guess I'll pose it as a question, be participatory. But in the report, in the committee's report, there's a section sort of like on challenges and a subsection on the IMT teams, and it talked about the 2024 comptroller audit. And we were doing the briefing for this, and you know, when I read it, I take notes and I bring it to these folks who are smarter than I am, and we talk about it. And you know, I think it's interesting because there sort of was, I guess it could be characterized as a criticism of IMT in terms of not being able to report specific like outcomes or data points. And I actually don't think that that's really a problem when you get down to it for this. Like, we can talk about all day long about how we need more data points for Be Heard, for efficacy, but like, I just want to understand, at least have you talk a little bit about why sometimes that isn't the thing that should be measuring success, because the whole idea of IMT is to be nimble enough and provide an opportunity for creativity, not be like bound by the things that you have to do when you're being reimbursed by Medicaid. So I was actually critical of like that portion of the comptroller's audit. And, you know, just wondering, like, if you have any suggestions in the face of that. Obviously, we come here and we talk about all these things and we're like, prove it works, because we're putting taxpayer dollars into it. And sometimes it's like not easy to put on paper, but like the IMT is like clearly filling a very unique gap and doing it in a way that has less constraints, but probably is harder to report on.
Yeah, I appreciate the question. I 100% agree with you. This IMT is designed to serve the people who have the most complicated situations, who have been failed everywhere else. So, you know, in line with that, I think using like traditional measures of effectiveness, outcome measurements, it's like not necessarily going to be appropriate. And even within an IMT team, you'll have 10 people for whom this set of criteria might make sense, but another 10 where it won't, right?
Right, like what's success,
What's
right?
success, right?
Because based on the environment that they're living in
Yes.
like a societal structure that like does not sort of create the ability for
Right.
people with mental health issues to like navigate the world the way
Right.
like
Right.
neurotypical people do, for example. Of like success could mean a day-to-day life that looks different than somebody else that may have more challenges as a baseline, but it's still a vast improvement from what they might otherwise be struggling with.
Yeah, right. So agree. I think just like the care and this engagement has to be unique for each individual person, and in this kind of setting, I think the definition for success is also necessarily going to be different for different people. So it might require, instead of like a lot of quantitative measures that we're used to looking at, more qualitative kinds of measures, which are more difficult to assess,
Yeah.
difficult to put together, but could also be more interesting also, and like more impactful and more powerful. And there are, I think, some standard measures that are still worth looking at in this population. For example, hospitalizations, right? Like you would definitely want an IMT team to decrease the numbers of hospitalizations
Right.
that people had, compared to prior to them joining IMT. So there are a few measures that are definitely still worth keeping track of.
Cool. Thank you.
If I can just
yeah,
quickly add
go
to
ahead.
that, I think also when we think about measures, it's important to consider what measures we as providers have control over and what we don't. So I know in our IMT teams that the percentage of our clients who we've successfully connected to supportive housing has decreased in recent years. It's not because of a change in practice for our teams. It's because we're just finding that the length of time it takes to get a person into housing has significantly increased. I think that still makes it a valuable data point to connect. Yeah, sorry about that. I was saying the length of time it takes to place someone into housing has increased. I think it's still a valuable data point to collect, but the outcome is not that provider isn't doing a good job. The outcome is we need to solve the systems behind which it takes so long to get someone of such high need into the housing that they deserve.
What story are we telling, or what conclusions are we drawing from a particular piece of data? Great, thank you.
And this might be a little floofy, but what about asking the person on IMT, what do they consider success, right? I think a big part of what everyone has talked about is the need for voluntary services. And I recently saw this like New York Times article that was about, the colds and bringing people in. And someone wrote in the comments something that like, it was like a light bulb moment. And it just said autonomy. People want to make choices for themselves. So I think also empowering people, asking people, what does success mean for you, right? So instead of just having quantitative measures of that, also should be like, have you had engagement with a peer, right? Like how many peer interactions you've had. It doesn't need to be like, how many times have you seen Van or, whoever. There are other alternative things. But I think asking people, it doesn't need to be like in a system, right? But asking people
What do you want to be able to do in
what
the
is
course of your
your
day?
goal?
Yeah.
And then if you want to quantify that, how many people made their goal, right? It could look a lot of different ways, but I think a part of this is also engaging people in their own care. And if we want people to accept voluntary services, we have to actually engage them and ask them what they want and what they need.
Thank you. And thank you to the entire panel. Oh, sorry. I forgot you were there.
I forgot I was here as well.
I know.
Yeah, this may be unconventional, but if you don't mind, if no one has to raise their hand if they don't want to, but how many people in the audience that are willing to raise their hand that have a family member that has some of the issues that were talked about? Yeah. Okay. Yeah. No, so I just wanted to to comment is that, I had to leave, so it's really not fair for me to comment to the zoning meeting. But I had a family member, may she rest in peace. It just seems to me, and I have very, very strong memories, first of all, the housing issue, unless having housed there's so many different levels of people that are in need. Just like, for example, I have Crohn's disease. There are people who have it severe, different, there are different levels of whatever it is, similarly. But if you have a family member or it's somebody who refuses to get help, I understood the comment about what they want, but part of the disease is the distinction between Crohn's disease or anything else is that the people who really are not well, unfortunately, they refuse to get help. That is the nature, part of the nature of the disease. I will just say to you is that for my family member, she was on a list for not only having residence, but for having the care. Having residence is important for someone who's not that sick and is okay with somebody, being able to go, having a place to live and being able to go on their own and get help wherever they need to get help. But if somebody is very sick, very sick, they had a space, for her, and they had a place where somebody would be coming in regularly, on a daily basis, twice a day, to see what was going on, whether she was taking her medication or whatever else. I'm just to try to make it brief. I'm talking about as a 10-year-old, because I remember it distinctly, is that when she was not well, she refused to take her medication. I used to go into a room, lock the door. She was willing to take a sleeping pill to get sleep. I used to, in order for her to take, the medication that she needed, the doctor said that it was more important that she take the medication and then she'll be able to get the sleep. I used to, some kind of horror movie, which is what it felt like as a 10-year-old. I used to open the capsule. I had to peel off the of the thing. Take out the capsule, empty it, crush the medication that she needed, put it in the capsule, put it back in there, and glue it perfectly shut, as well as to get her to take the medication. So I'm just, I don't want to spend more time. I'm just saying that it first of all, the city. I'm just saying my opinion.
Okay.
This
Just
is
my
one.
seconds, Councilmember.
Yeah, you could buzz me. The city. This is one of the areas that I would just say is that the city. It's impossible for any government to be able to do what needs to be done. The organizations in the neighborhood. They know what they're doing, and we need more of it. You mentioned more of it, and supervision. And in terms of asking the person what they want, obviously, somebody who's sick, can't do that.
Thank you, Councilmember. I know Jordan's
Okay.
gonna have a lot to say about this. I think I want to engage with that a little bit. I think at least what I have learned is that a refusal is not a refusal on its face, and so you've got to be able to provide options that are going to be responsive to. Like a person might not be able to get out the door to get to a program twice a week, but they're going to be okay if you can get a team to their home. Or a person might need a supportive housing setting otherwise. Or maybe a person, needs intravenous treatment versus being able to take pills. And so I think, while we can't solve for everything as a government, I do think that we probably can agree that there's a whole lot that we have not done yet. Like the span of what we have not done is this big. And so I certainly, don't want to jump prematurely because we haven't done our job. In making sure that we are providing as much choice and autonomy as possible. I think that's really important. And also that people with SMIs live really, really productive lives. And I'm talking about the intersection of what we consider really serious SMIs. There are people with schizophrenia. There are people with schizoaffective disorder. A few months ago, I was just reading the collected schizophrenias, right? We're talking about people with what we consider or would assume without more information would be somebody who could not, quote unquote, function in our communities, but can create communities, support systems where there are periods of struggle, but also there's incredible beauty in what they bring into our world. I found that book to be transformative, among them a bunch of other obviously writings and stuff. But what do you think about this?
So first I want to actually introduce a new idea that I don't know if everyone knows about, but they're called PADS, or Psychiatric Advanced Directives. Can I just does anyone, even in the audience, do people know what that is? Has anyone ever heard of it? Yeah. Oh, sorry. I'm sorry. I didn't mean to.
You can.
I didn't mean to steal it.
Go for it.
I'm sorry. I wanted to, sorry. Gotcha. Anyway. We only got so many jokes, right?
But you could plan for it.
But anyway, yeah. So the point of the Psychiatric Advanced Directive is like a health advanced directive, right? And you work with your psychiatrist to basically create a plan that says, if X, Y, Z happens, this is what I want. This is how I want to be treated. This is who I want to respond. It is a legal document. It doesn't supersede everything, but I think there are ways to incorporate someone's voice. And I hear you about, your experience and, the vastness of the issue, right? It's not one size fits all. And I think that's what we're all saying, right? And I think that part of why it's so important to engage the person, even if we may disagree about cognizance or insight on one's own mental health, is that we got to work together, right? And I think that, we need to engage the person to say, what do you think, right? And I'm going to just give a quick story of an example that everyone has heard. If you've ever heard me testify, I've probably told this story. But basically, I had met a woman who had left Bedford Hills, and she was sleeping out on the streets. She had, PTSD, et cetera, whatever. She did not shower. Now, the reason why she did not shower was because it was a means of self-defense. Now, the reason why I'm saying this and why it's so important to engage with that person and talk to them is because very often we could, especially under this expanded AOT Kendra's Law order, we could say this person's not taking care of themselves, they reek of urine and feces, blah, blah, blah. When in reality, she knew what she was doing. She was making a conscious effort to actually smell as bad as she could because she thought this will keep people from sexually assaulting me as I sleep. So I think about this story all the time because there are pits of information that we can get to that also build trust. So for instance, if you had a peer responding to that person who had experience with unsheltered homelessness, they might know that from the get-go, and then they wouldn't have to ask that person questions about their cleanliness. So it automatically builds this kind of foundation of trust and camaraderie, which puts you in a better position for someone accepting care. So again, it isn't necessarily that it's a like you're doing it for show or anything, but like actually engaging the person in their health has better outcomes all around. So thank you, and I appreciate your openness to my response.
Yeah, I also thank you, council member, because I think it really contributed to some good testimony and discussion. And thank you to the panel. Okay, panel number 2 is Razia Begum, Sofina Tani, Kumari Cruz, Fiona O'Grady, and Jonathan Chung.
I'm good. Hello there. Good to see you again. And if I may, my executive director couldn't come, so I'm going to actually read her testimony, but I'm handing you both mine and I'm orally reading hers.
Got it.
Thank you. I am Fiona O'Grady. I am the Government Relations Director for the Samaritans of New York. We provide a confidential and anonymous suicide prevention support for New Yorkers 24/7. As a role, we also we have a seat on the National Council for Suicide Prevention and work internationally with befrienders worldwide. There's over 400 branches of Samaritans in over 40 countries. It's the largest global suicide prevention network. We support all 3 items before you today. And again, I think I'm echoing what I'm hearing, and I'm glad it's in my black and white also, which is trust is what is at stake today, and trust depends on transparency. And at a minimum, the council should have access to aggregate reporting on key 988 performance indicators. And also, they can do that without compromising confidentiality as it is already being collected. So we're talking about the call, chat, text and chat volume, waiting times and call abandonment rates, cross-state routing and use of national backup centers, which you've all mentioned, risk levels identified during contacts, emergency dispatch and mobile crisis deployment, and referral patterns and the types of services callers are connected to. Transparency allows policymakers to understand how the system is functioning, where people are being directed for care, and where improvements may be needed. But transparency is only part of the larger conversation. As New York strengthens centralized crisis systems like 988 and SPOA, it's also important to remember that suicide prevention does not occur only within centralized intake systems. It happens across the broader health and the social service landscape, as well as, I think, demographics and the downstream issues that lead to crisis. Community organizations, healthcare providers, schools and local hotlines, they all play an important role in helping people reach support. When we become over-reliant on a single system, whether it's SPOA, 988, we risk weakening the very safety net we're trying to build. Large systems are designed for capacity and scale. Community-based services are often designed for trust and relational continuity. These are different strengths. A well-functioning crisis system needs both. 988 may be the front door to crisis care, but that does not mean we should turn all the other lights off. And I'd also like to add that when you look at the best practices in suicide prevention, the Army and Navy did the best national research, and what they found was that autonomy and allowing the person who is, either suicidal or has had attempts, etc., giving people choices amongst services worked. And that was the largest, because it is a closed cohort of people, it was the largest study. And basically what they're saying is diversity of services and choices that persons can make in their autonomous self works best for suicide prevention.
Good afternoon, Chairs Caban and members of the committee. My name is Kamari Cruz, and I am Director of Bereavement and Public Education Services at Samaritans of New York. In my work, I support individuals and families who have been touched by suicide, and I work closely with communities all across New York City to strengthen suicide prevention education. From this perspective, I want to focus on something that Fee mentioned and everyone else prior had mentioned, something that determines whether crisis systems actually work, which is trust. A crisis system only works if people trust it enough to reach out. For many people, that decision depends on whether they believe that they will maintain autonomy, whether their conversations will remain completely confidential, and whether seeking help could lead to consequences they didn't intend. New York City has made important commitments to least restrictive crisis response and to minimize unnecessary police involvement in behavioral health emergencies. From a suicide prevention perspective, crisis interventions should prioritize autonomy, voluntary engagement, confidentiality, and harm reduction and least restrictive care. These principles matter because they directly influence whether people feel safe enough in asking for help. If people fear losing control when they reach out, they may not reach out at all. This concern is important for communities that have historically experienced harm within formal systems, including undocumented residents, LGBTQ plus youth, and communities of color. Other important realities is that many people never enter crisis systems through formal entry points. They may reach out first to a trusted community organizations like Samaritans, a healthcare provider, school counselor, or a local hotline. These trusted relationships often represent the moment when someone first feels safe enough to talk about what they're experiencing. For many individuals, the difference between reaching out and remaining silent is whether they can do so in a way that feels safe and familiar. A well-functioning crisis system therefore needs both scale and trust. Large systems provide capacity, community-rooted services provide connection. When those two strengths work together, people are much more likely to reach the support they need. Thank you.
Good afternoon, Chair Tiffany Caban and members of the Committee on Mental Health and Substance Use. My name is Razia Begum, and I am the Mental Health Clinician Supervisor at the Arab American Family Support Center, also known as AAFSC. AAFSC provides linguistically accessible, trauma-informed, and multi-generational services across all 5 boroughs. While our doors are open to all New Yorkers, we have deep expertise serving Arab, Middle Eastern, North African, Muslim, and South Asian communities. With services offered in more than 20 languages, we support over 20,000 individuals each year. As members of the Asian American Mental Health Roundtable, we are here to highlight the urgent mental health needs of Asian and immigrant New Yorkers, and the importance of language access, transparency, and accountability within the 911 and 988 systems. Over the past year alone, AAFSC has experienced a 54% increase in demand for mental health services. We see pervasive fear and anxiety. Families delay seeking care. Parents fear sending their children to school. Community members avoid medical services and hesitate to report violence or abuse. Anti-Asian hate, immigration enforcement policies, and ongoing federal uncertainty have intensified distress. At the same time, stigma, limited English proficiency, and distrust of law enforcement prevent many from seeking help in moments of crisis. Many hesitate to call 911, and language barriers continue to limit meaningful access to crisis support. While we support greater transparency in 911 data and efforts to strengthen 988, reforms must include meaningful community representation, expanded multilingual capacity, and equity-centered accountability, measures to ensure immigrant communities receive health-based responses. At AFSC, we provide free mental health care in trusted, culturally familiar settings, alongside domestic violence services, preventive services, housing navigation, legal support, and food assistance. This holistic model is essential for long term well being, yet sustaining it is increasingly difficult as demand rises. We respectfully urge the Council to invest in culturally responsive, community based organizations, strengthen multilingual capacity across 988, develop equity centered performance metrics, and fund public education campaigns delivered through trusted messengers. Improving transparency is critical, but true equity requires sustained partnership with the communities most affected. Thank you for your time and consideration.
Thank you, Chair Caban and members of the committee for providing us the opportunity to testify. My name is Sophie Natani, Senior Program Coordinator at the Asian American Federation. We are testifying as part of our Asian American Mental Health Roundtable, a coalition that works to address mental health care. The Roundtable continues to report a sharp rise in mental health challenges among Asian New Yorkers, driven by aggressive immigration enforcement policies, persistent anti-Asian hate, and ongoing uncertainty at the federal level. Fear of deportation and surveillance, compounded by stigma, limited English proficiency, and distrust of law enforcement directly shapes how individuals seek help. As council members noted, the recent case of Jabal Chakraborty illustrates how systemic issues with 988 and 911 can fail our communities. His family sought help through 988 during a mental health crisis, yet the response ultimately led to a police involvement and escalated into violence. This is not an isolated incident. Experiences like this deeply affect how Asian New Yorkers perceive crisis response systems, shaping whether individuals feel safe calling a hotline or interacting with police during a mental health emergency. Establishing a task force and launching a public education campaign are important first steps toward greater transparency and accountability around 988. However, without a clear commitment to equity, robust language access, and meaningful community collaboration, these reforms will not fully help the people who need them the most. We urge the Council to consider the following. Consult Asian-led and immigration-serving community organizations when reviewing 911 reporting data. These groups are already providing crisis support and can ensure data reflects lived realities, not just system metrics. Include Asian-serving CBOs on the 988 task force to ensure recommendations reflect the needs of immigrant communities. Directly fund culturally and linguistically competent CBOs because they're already delivering crisis and emergency mental health support, but lack funding to meet growing demand. Build partnerships with trusted community hotlines for smoother referrals and strengthen language access across 988, as well as provide culturally competent training and mental health support for staff experienced vicarious trauma. Develop equity-centered performance metrics and publish them annually. And finally, deliver multilingual public education campaigns through ethnic media, faith institutions, and grassroots partners to increase awareness and reduce stigma. Thank you for your continued leadership and for the opportunity to testify today.
Good afternoon, Chair Kuban, Councilmember Felder, members and staff of the committee. My name is Jonathan Chung, and I'm testifying on behalf of the National Alliance on Mental Illness of New York City, the only nonprofit in the city providing free, direct, and extensive family support and peer services to New Yorkers caring for someone living with mental illness. I also serve on the steering committee of the Correct Crisis Intervention Today Coalition. Thank you for holding today's important hearing. First, I want to affirm NAMI NYC's support for Intro 722, sponsored by Councilmember Schulman, which would increase transparency in the city's Be Heard program. Requiring regular reporting on mental health emergency responses will allow policymakers and the public to better understand what is working and where improvements are needed. We also support the pre-considered introduction sponsored by Council members Lee and Caban, which would establish a task force to study and strengthen the 988 system and require a public education campaign about 988 and the available crisis services. The 988 Suicide and Crisis Lifeline is a critical tool that connects New Yorkers to trained counselors, clinicians, and peers. The city must ensure it is well-resourced and that every New Yorker knows how to access it. NAMI NYC urges this committee